Rakesh, good morning.
Good morning, sir.
Good morning, Rakesh.
Good morning, Dr. Sanjay. Good morning. Thank you. Thank you.
Hello, Sanjay. How are
Hello,
you?
sir. Hello, sir. I am good, sir. I am very good, sir.
Dr. Jyotsna is also joined. Thank you, Dr. Jyotsna.
Good morning, sir. I am Dr. Ashwini. I am working with Professor Badada in PGIM Chandigarh.
Hi, Dr. Ashwini. Good morning.
Good morning,
Good morning,
Dr.
sir.
Ashwini.
Good morning, Professor Rakesh. Good morning, Professor Sudhakar Rao, sir.
Good morning. Good morning. Thank you.
Thank you. Thank you very much, sir. We
Good
are
morning.
working as a team in a department in a PGI under Dr. Badada, sir.
So we have with us Dr. Siddharth Chakravarti is here. His name is coming as Vivek. Can you rename yourself, Dr. Siddharth? He is a endocrine surgeon here in Hyderabad. Dr. Sanjay, Dr. Siddharth is
Okay, good.
working in Apollo here. He has done his endocrine surgery from CMC Vellore.
Oh, right.
And he has been the key person behind organizing this meeting today.
Okay, good, good. Nice meeting, Dr. Siddharth.
You are still muted, Dr. Siddharth.
Yes, sir.
We have Dr. Sham who has joined. Dr. Sham, good morning.
Yeah, morning, Dr. Rakesh. Morning, everyone. Yeah. Morning, Dr. Sudhakar Garu.
Yeah, Namaskaram. Good morning.
Yeah. Hello, sir. Yeah.
Hi, come.
There's some noise coming from one of the mics. I think. Some noise.
Good morning, Dr. Pooja.
Hello, good morning, Dr. Siddharth, and good morning, everybody.
Yeah. Dr.
Good
Pooja
morning,
is
everybody.
a professor of endocrine surgery from KGMU, Lucknow. She worked with me in Vellore for almost 6 years. We worked together. She's my teacher too. Welcome, Dr. Pooja.
Thank you, Dr. Siddharth.
Welcome, Dr. Pooja.
Thank you.
Nice
to meet endocrinologists.
Good morning, Dr. Siddharth.
Good morning, sir.
Dr. Ashwini.
Hi, good morning, sir. Morning.
Good morning. Thank you. And good morning, Dr. Pooja.
Good morning, Ashwani, sir. Good morning.
Yeah. Thank you. I'm PGI. You are in KGMU?
Yes, I was earlier in CMC Vellore. Before that in SGPGI, and then I was basically from Lucknow, so moved back to KGMU.
Okay, I did my DMB from this thing, SGPGI Lucknow way back in 2000, I think 98 to 2000. I was there in SGPGI.
Okay, wow.
That time,
I was there
Dr. Yeah.
Hello, Dr.
Sanjay,
Pooja.
Gambhir and Dr. Pardon?
Hello.
Sanjay. Yeah, Dr. Sanjay is with us. Yeah.
Hello, Sanjay, sir. Yeah.
Hello, Dr. Pooja. We met
Hello,
in SGPJ sometime.
Yes, sir. Nice to meet you after a long time.
Yes.
Dr. Deepak Abraham also joined. So I think we have 2 minutes to go.
Good morning, Deepak, sir. Good morning, Dalpati.
Morning, everybody. Morning.
Morning, sir.
Good morning.
Morning.
Dr. Deepak is the professor and head of Department of Endocrine Surgery from...
Hey, correction, not head anymore, da.
It's ex-head, ex.
It's all a rotating head, yeah.
Sir is very well known, so we all know him.
Rakesh, yeah, we met at the board meeting here in Bombay.
Yes.
Yeah.
Dr. Tushar sir has joined. Dr. Dalapati also has joined.
Yeah.
Welcome, Dr. Ritu.
Thank you, Dr. Siddharth.
Hi, Dr. Ritu. Nice to see you after a long time.
Hi, nice to see you too, Dr. Pooja.
You're labeled as Amaya Ritu.
Yeah, I'm not able to change it, sir.
You should.
I think you can just go to the participants and you'll have that option of renaming.
Other thing is the Idea Clinic, the host can do that, Siddharth.
Yes, sir, I will.
They can do a rename.
Oh, yeah. She has been able to do it. Good morning, Dr. Tushar. Good morning.
No, it's labeled as Pooja now. It's Dr. Ritu.
Dr. Tushar, good morning.
Double E.
Good morning, sir.
Salami.
Siddharth?
I think it's 10 o'clock. Shall we start?
Yes, sir.
Yeah.
Yes, sir.
It is 20
You
people.
please
have
start
joined.
the session, sir.
Yeah, please. So we'll request Dr. Sudhakar Rao to give a short introduction, then.
Thank you, Dr. Siddharth and Rakesh. I welcome all the faculty, delegates, and throughout the India. We have a nice faculty, excellent, very standard faculty of Indian endocrine and endocrine surgeons and endocrinologists. Throughout if you go through, even chairpersons are very renowned chairpersons are there. Parathyroid, Dr. Siddharth is architect, as I already told, and co-architect is Dr. Shyam. And we have a very good follow-up today with this one. I think everybody will appreciate. I welcome again all. Rakesh, please.
Thank you, sir. Good morning to all. A warm welcome to all of you to this parathyroid update. I think parathyroid disorders are not so uncommon as they are thought of, and we have very different presentations, and it's always a challenge managing parathyroid disorders. So I think today I would like to congratulate Dr. Siddharth for conceiving this idea and conducting, organizing this program, Dr. Shyam for giving the support for organizing this program, and today we have all the who's who of endocrinology who's who of parathyroid disorders in the country. Today we have all of them here today in this meeting. So I'm very sure that this meeting is going to be a very fruitful meeting. So we have with us Dr. Sanjay Badada, who is the professor and head of endocrinology at PGI Chandigarh. He has been working on parathyroid disorders for the last 1 decade, and he has phenomenal work in this field. He is going to tell us the lessons which we have learned from the parathyroid registry, and is also going to be there with us for the entire session to give his viewpoints. And then we have amongst the nuclear medicine specialists, we have Dr. Ashwini Sood from PGI Chandigarh. He is the professor of nuclear medicine there, and we also have Dr. Jyotsna Rao from Apollo Apollo Hospital in Hyderabad. And then we have a galaxy of endocrine surgeons, the stalwarts in the field of endocrine surgery, Dr. Amit Agarwal from SGPGI, Dr. Deepak Abraham from CMC Vellore, Dr. Pooja from KGMU, and Dr. Ritu from Ritu Johari from St. John's, Dr. Ritu from St. John's Medical College, CMC Vellore. And then we also have we have several different endocrinologists from the city of Hyderabad available, who are going to be there. Dr. Ravi Mehrotra, Dr. Bipin Sethi, Dr. Neelaveni, Dr. Meher Prasad, Dr. Shyam Kalwalapalli, Dr. Samantha. All of them are going to be here. And then we have a nephrologist, Dr. Manisha Sahai, will be chairing a session. So I think we have a very well-designed program lined up, and I would not like to take more time, and I would like to once again extend a warm welcome to all of you, and look forward to a very interactive and interesting program. Thank you all for being here. Over to Dr. Siddharth.
Yeah. Thank you, everyone. Thanks, Idea Clinic. Thanks, all the participants, the chairpersons, and the speakers for joining on a Sunday morning. So we are going to start this session. I request everyone to mute themselves. Whoever has to talk will be unmuted. And we encourage you to ask the questions in the chat box, and we shall discuss them after end of each presentation. So I request Dr. Pooja Ramakant to give a few words about the first speaker, Dr. Ritu from CMC. Dr. Pooja.
Thank you. Thank you, Dr. Siddharth. Dr. Ritu John is Associate Professor of Radiology Department at CMC Vellore. And I remember my long association with her and long discussions we had on patients. She's a very focused, very dedicated endocrine radiologist. And she's very passionate about her field. So it's very good for surgeons to have dedicated radiologists where we can always discuss, relook the disease, relook the lesions, especially in parathyroids. They need a lot of dedicated radiologists, which are present, available in very few centers. So that way we are lucky to have her today. And we look forward to hearing her expert talk on that topic. Welcome, Dr. Ritu.
Thank you, Dr. Pooja. I'll share my screen. So today I will be giving you an overview on 4D CT imaging of the parathyroid. We'll go through the technique, a few cases, then indications, then finally deal with a bit on diagnostic accuracy and the radiation risk associated with the 4D CT. So 4D CT is a technique that records multiple images over time. It enables accurate preoperative localization of parathyroid adenomas, thereby facilitating minimally invasive parathyroidectomy. It was first reported in literature in 2006.
Dr. Pooja, could you put it on full screen?
Are you able to see?
No, we are not seeing the full screen. Probably you can stop and share again. Stop sharing and share again.
And probably you might want to share the entire screen, the first option while you are starting to screen share.
Are you all able to see? Shall I continue?
It's not full screen, but if you wish, you can continue. It's okay.
It's not full screen now?
Yeah. We can see the slides on the side.
Could you please try stop sharing and then resharing once again? Yeah, perfect.
Now? Okay. Perfect. So the most commonly used initial modality to diagnose parathyroid adenoma is a neck ultrasound and nuclear scintigraphy. And 4D CT is more widely used as a second-line investigation or in patients undergoing repeat surgery. But it is important to remember the preferred first-line imaging algorithm may vary from institution and institution and depends on the surgeon, the radiologist, and what techniques are available. So coming to the technique of 4D CT, the initial study that we do is an unenhanced CT to cover the thyroid gland. This is followed by 2 or 3 contrast-enhanced studies after giving IV contrast that cover from the angle of the mandible up to the level of the carina. And after this, 3 phases can be done. The arterial phase at 25 to 30 seconds, a venous phase at 65 seconds, and a delayed phase at around 3 minutes. But the optimal number of phases to be done is actually undetermined. So why do we do a 4D CT? It is observed that parathyroid adenoma has a characteristic type of enhancement. That is a peak enhancement at the arterial phase a rapid washout of contrast material from the arterial to the delayed phase, and low attenuation on the unenhanced images. There can be a few mimics, which include lymph nodes, which have less intense arterial phase enhancement with mild progressive enhancement on venous and delayed phases. Small vessels can also sometimes mimic lesions, but if we follow the course of the vessels on coronal and sagittal reformated images, we can be able to determine that they're actually vessels. And exophytic thyroid nodules can also pose a problem sometimes, and that is the importance of the unenhanced phase. So this is a graph showing the enhancement over time. On the x-axis, we have the time, and on the y-axis, we have the degree of enhancement. The yellow line is a parathyroid adenoma, which shows that there will be peak enhancement at around between 25 to 30 seconds, and then it has a rapid washout. This is opposed to a lymph node in which that is depicted by the purple line. There is very mild arterial phase enhancement, and it is progressive on the venous to delayed phases. So this is how we differentiate an adenoma from a lymph node. This is an image showing sequential arterial phase over time. We can see that there is actually a small lesion seen posterior to the left lobe of the thyroid, which is best seen between 26 and 35 seconds. On the earlier arterial phase images, it is not seen, and on the non-contrast, it is not seen at all. As time progresses, we can see that there is washout, and it is less enhancing than the thyroid gland at around 40 seconds. Now we'll come to a few cases. This is a 29-year-old lady who had MIBI and ultrasound negative, and she underwent a 4D CT, which showed a well-defined arterial phase enhancing lesion that is seen posterior to the right lobe of the thyroid. And this lesion has got washout on the venous and delayed imaging. Now, sometimes this can mimic an exophytic thyroid nodule. That is the importance of a non-contrast study in which we can see that lesion is hypodense. Normally, the thyroid gland will be hyperdense owing to the fact that it contains iodine. So this is the importance of a non-enhanced phase. This is an example of a lymph node. You'll see on the arterial phase, it does not really have any enhancement, but there is mild progressive enhancement on the venous and delayed phases. This is a lymph node, and what we saw earlier is the adenoma. This is another example of a patient who had persistent hyperparathyroidism, and we can see that there is a very small enhancing lesion seen posterior to the right lobe of the thyroid. This was also seen on ultrasound. The 4D CT was done because she was a previously operated patient. So here we can see that 4D CT allows us to see very small lesions and gives us very good anatomical detail. This is a 16-year-old girl who underwent ultrasound in MIBI, and the lesion was not localized. She then underwent a bilateral cervical exploration, and post-op she had persistent hyperparathyroidism, after which this 4D CT was done. We can see a well-defined intensely enhancing lesion that is seen in the right carotid sheath, and on the venous image that lesion has got washout. This is a sagittal image showing the characteristic oval appearance of the lesion. So this was an ectopic parathyroid adenoma. As I said, the ultrasound in MIBI was negative, but on retrospect, when we looked at the MIBI, there was actually increased uptake in the region of the submandibular gland, and that's why probably it was not picked up. So ectopic inferior parathyroid gland can be in the thyrothymic ligament, mediastinum, carotid sheath, or thyroid parenchyma, whereas a superior parathyroid ectopic lesion is in the retropharyngeal or retroesophageal position. This is another example showing a well-defined heterogeneously enhancing mass in the anterior mediastinum with areas of necrosis and heterogeneous enhancement. This also turned out to be an ectopic parathyroid inferior lesion. This is also an incidental Brown's tumor. This is a lady who underwent ultrasound in MIBI, and ultrasound showed a left inferior parathyroid lesion, which was also seen on the MIBI. She underwent right inferior parathyroidectomy, but post-op she had persistent hyperparathyroidism. When she underwent 4D CT, we can see that there is a well-defined arterial phase enhancing lesion that is seen just lateral to the esophagus with washout on the venous face. And this is the advantage of the non-contrast study, showing that the difference between the thyroid and the parathyroid. Parathyroid will be hypodense, whereas the normal thyroid will be hyperdense owing to the iodine that it contains. So this was probably a descended superior parathyroid lesion. This is another example showing a small enhancing lesion posterior to the thyroid. This is just to show you that sometimes if we are confused, if a lesion is arising from the thyroid, if we actually do the reformated images, it's the sagittal showing that there is a clear plane between the lesion and the thyroid gland. So we know that it is a parathyroid adenoma. This is another interesting case in which the patient underwent an ultrasound which showed two lesions. One lesion lateral to the left lobe of the thyroid and another lesion inferior to the thyroid. You can see that there are two separate lesions seen on the coronal CT. Now, when we go to the plain CT, the lesion inferior to the thyroid is actually hyperdense. And the lesion lateral to the thyroid is hypodense. So this turned out to be a parathyroid adenoma, and this was an ectopic thyroid. With 4D CT, if not done well, can sometimes pose to have some artifacts. For example, this is contrast seen within the subclavian vein, and we can see that it is causing a lot of artifact here. This is called streak artifact. And this black line is beam hardening artifact from the clavicle. So these two artifacts together it allows us not to be able to depict lesions in the lower neck. This patient underwent an ultrasound which actually showed a left inferior lesion, and because of these artifacts, it was completely obscure on the 4D CT. So the main advantages of 4D CT are the anatomical localization, which is important, especially in post-operative patients. CT can tell you the number and size of the lesions. It can tell you abnormalities in the thyroid gland, and it can tell important anatomical variations for surgery, that is aberrant right subclavian artery and a right-sided aortic arch with an aberrant left subclavian artery. So the main indications of 4D CT would be lesions not localized on ultrasound or MIBI, that is when you have ectopic glands also, and also in post-op patients who have recurrent or persistent hyperparathyroidism. 4D CT has a very high diagnostic accuracy when it comes to single gland disease. The reported sensitivity ranges from 92 to 94%, but this becomes less in patients who have multi-gland disease. It is around 43 to 67%. In patients with recurrent or persistent hyperparathyroidism, the sensitivity is from 50 to 91%. Very sensibility is the same. But what is the main problem with 4D CT? It is the radiation risk involved, which is especially so for younger patients. We are mainly worried about stochastic effects of radiation. What do I mean by stochastic effects? Basically, stochastic effect is the probability that something will occur when the dose is increased. So you give a higher dose of radiation, there is a higher chance that the stochastic effect can occur. There is no threshold dose for stochastic effect. And the stochastic effects are basically cancer and genetic mutations. There have been several studies that have evaluated the radiation exposure from 4D CT and that from parathyroid scintigraphy. This is a study by Hong et al. Published in American Journal of Radiology in 2015, in which they said that the effective dose from 4D CT was 28 millisieverts as opposed to scintigraphy, which is 12. Just for comparison, a chest X-ray is 0.1 millisievert. They also said that the highest dose from 4D CT was to the thyroid glands and then to the salivary glands. But they also said that it may be okay for older patients because there will be negligible increase in lifetime risk of cancer. This is another study by Mahajan et al. Published in World Journal of Surgery in 2012, which showed effective dose of 4D CT was 10.4 and scintigraphy was 7.8. And the dose to the thyroid was 57 times higher. And they said that it should be used judiciously in young patients with PHPT. There are other studies also. This was published in 2017, which showing that the effective dose was between 15 to 20, depending on the number of phases of CT that were done, but the risk is low in older population. And this was a study that showed the radiation risk to be quite low, actually, 5.56 versus scintigraphy, which is 3.33, but I think they used a low dose technique. So what we can see here is that there is variation in the effective dose among studies, but whatever it is, the radiation risk is high. And 4D CT should definitely be used judiciously, especially in young patients. the benefit of detecting a parathyroid adenoma and the benefit of minimally invasive parathyroidectomy over bilateral exploration should be considered along with a radiation risk. It is also important to remember that there is no universally reported algorithm and there is variability in its sensitivities for different imaging modality, and no imaging technique is clearly superior to another one. And selection of the initial imaging study depends on everybody's preference at that center, the surgeon, the radiologist, and regional expertise. So in conclusion, the role of 4D-CT is to enable accurate localization of parathyroid adenomas to facilitate minimally invasive parathyroidectomy. It does have a role in multiglandular disease, but we saw that the sensitivity is less as opposed to single gland disease. The characteristic enhancement of a parathyroid adenoma is what allows for its confident diagnosis. And 4D-CT is best used as a problem-solving tool and should be used carefully in young patients because of the lifetime risk of cancer, albeit it is quite small. Thank you.
Thank you, Dr. Ritu, for the wonderful talk. I request the chairpersons to give their comments, and after that, there are some couple of questions which we'll ask the speaker to answer.
Thank you, Dr. Ritu. It was a nice description and you have presented nice cases also. Did you find any difficulty in having problems with lymph nodes or any other differential lesion which mimicked like a parathyroid and was not really a parathyroid?
Yeah, sometimes these lymph nodes can pose to be a problem, and sometimes these parathyroid adenomas, like they've been classically described as having intense arterial phase enhancement. But sometimes if the timing of the contrast is not done at the correct time, or if the patient has cardiac issues, the enhancement can be confused with a lymph node. But then there are other things that we can look at. The morphology of the lesion is usually oval, elongated, and lobulated. And if we have a doubt, we can do a focused ultrasound rescreening.
Okay, and any short-term and long-term side effects of 4D contrast enhanced, like radiation toxicity, is it short-term and what are the long-term hazards?
There are no short-term hazards of doing a 4D CT. It is mainly long-term, and it depends on number of CTs that the patient gets done. There is definitely increased radiation with 4D CT, and they've shown a lifetime risk of thyroid cancer in young patients increasing. But in some studies have also shown that after a couple of years, it is similar to the background radiation and things like that. But there's definitely a risk in young patients. There's no short-term effects.
Okay, sure. Thank you.
There's one question in the chat box. Can 4D CT be a good modality to locate parathyroids in neonatal severe hyperparathyroidism?
Neonatal. I've not had any experience with that, but what about an ultrasound may be better?
Yeah, I think probably in the neonates, the children, the fat contrast may not be there, Dr. Ritu, no? So to make a lesion, so differentiating.
And also it's a lot of radiation, no? Especially
a lot
for
of radiation for children, yes.
Can we invite the chairperson, Dr. Siddharth?
Yes. Dr. Sanjay Barada, sir, can you give your comments, please?
Dr. Neelavani.
Yeah, so anyway, we don't have much experience with 4D CT, but recently we have started our institute. So obviously, as Dr. Ritu told, it is not a first-line modality, it is a problem-solving modality because of radiation and its sensitivity. But in neonate, it may not be very useful because artifact is one of the issue, and obviously it is difficult to immobilize the neonate while taking the scan. So that may not be very good, as in addition to the, obviously radiation is one of the issue. Yeah.
Can I ask Dr. Neelavani ma'am to give her comments?
Yeah. So good morning, all of you. I think a wonderful presentation on the role of 4D CT in evaluation of a primary hyperpara. But I just So we have a functional imaging with Sesame B, right? So in what situations, like in the sense, probably I personally feel the role of 4D CT may be much more for the surgeon perspective, in the sense it will help the surgeon looking at the surrounding structure. That's what I understood. So because functional imaging will be revealing the localization of the source of the increased PTH. But the 4D CT role, I think, if I am not wrong, so 4D CT looking at the isolation, in the sense localization, as well as the looking at the surrounding structures, which may give much more better idea how to go about for the surgery. That's what I understood. And with associated risk of increased exposure to the radiation, so we have to be choosy in selecting this modality in evaluation of the patients. So can in the sense, is it right, or something in the sense in which situations is really helpful? Because we are all managing with the ultrasonography or the CT modality which is available right now with us, apart from the functional imaging. So what exactly it offers superior advantage in which situations?
Basically, 4D CT is useful when the lesion has not been localized on the ultrasound and the MIBI, for patients who have ectopic lesions, and in patients with recurrent and persistent hyperparathyroidism, because they give very good anatomical detail, especially in the post-operative neck.
Dr. Dalapati has a question. Dr. Dalapati.
Can I interrupt?
Yes, madam.
So basically, functional imaging helps in localization, either in the ectopic or within the gland, or exactly how does it help, in a sense? So in which situations is it really combination of a functional imaging with the 4D CT?
When the MIBI has not localized the lesion, ma'am. When the MIBI has not localized the lesion and on ultrasound it may be discordant, then we do the 4D CT.
Okay, thank you.
We don't do it as a first line modality.
Thank you, Dr. Ritu.
Welcome.
Dr. Dalapati, you had one comment.
Yeah, regarding Siddharth's question of neonatal severe hyperpara, I don't think imaging is required at all, because it will not be helpful in any whatever imaging we try to do, an ultrasound or a CT or a 4D CT, whatever it is. Actually, we have done around 6 cases of neonatal severe hyperpara as per our experience. Out of those, as an academic exercise, we did ultrasound as well as STEMI in 5 cases. Out of those, we could not, no imaging could detect any of the hyperparathyroid in any of the cases in the neonates. That is our experience of the 6 cases. Moreover, the parathyroids, as we think in other adult parathyroid, here the parathyroids will be normal sized. It is not enlarged. That is the only issue, because it is not enlarged. It is usually less than 1 centimeter or something like that. So I don't think imaging is, because moreover we need to explore all the 4 parathyroids as well as all the embryological exploration of the descent of the parathyroids wherever it can be found. So imaging, it is not useful and it is not helpful what we have seen. That's what.
Okay, due to lack of time, we will move on to the next session. I request Dr. Sanjay Barada sir to introduce our next speaker, Dr. Ashwini. Dr. Barada sir.
Thank you, Dr. Siddharth, for this opportunity to introduce Dr. Ashwini. So I am very pleased to introduce Dr. Ashwini. Dr. Ashwini is Professor of Nuclear Medicine at Department of Nuclear Medicine, PGI MER, Chandigarh. And he is one of the finest nuclear medicine physicists I have met so far. And is a lot of publication, and he's having keen interest in parathyroid imaging. And he is going to speak on role of choline PET CT in parathyroid imaging. I am very eager to listen to Dr. Ashwini. Over to Dr. Ashwini.
Thank you very much, sir. So, and thanks, Dr. Siddharth, for giving me the opportunity to talk about parathyroid imaging.
Yes, we can see your slide. And
you can see my slides. Okay.
Here
so, Before going to the talk, I would like to thank Professor Badada sir, as he is he has a very keen interest in parathyroid management, and every time whenever a case would be there, the whole team would be discussing each and every case. And he has maintained a Indian PHPT registry, and we have a lot of data also. So I'll be talking about role of choline PET, which has recently emerged. So we all know that there are indications for doing parathyroid imaging, and though parathyroid imaging is not done for diagnosing the hyperparathyroidism, it's just to do the localization of one or more hyperfunctioning parathyroid glands and exact localization of ectopic or supernumerary glands before surgery is paramount, because we know that around 16% glands are ectopic and 12% would be seen in neck and around 4% would be seen in mediastinum. And identifying the site of disease recurrence when the second surgery is being done, so accurate localization is very important. Use of gamma probe can aid in during surgery or identifying parathyroid glands with lowest uptake, like preserved or partially autografted. We need to have an imaging for that. So we all know, just about a brief about the histology, we all know that the parathyroid glands are composed of chief cells, which are most abundant. They have a big nucleus, but poor in cytoplasm. They have a main function of synthesis and secreting of a parathyroid hormones. And choline kinase has a role in to play in a chief cells. Apart from that, we have a oxyphil cells in the parathyroid gland, which have a acidophilic cytoplasm. They are rich in mitochondria. The function is unclear. Apart from that, we have a transitional oxyphil and water clear cells. So coming to the uptake of the choline, as I am talking about the choline. So the uptake mechanism, it has a dual uptake. Choline being a positive electric charge, it enters through cell, through the membrane transporter and accumulates in the both oxyphil cells and the chief cells. We can see from the blood, choline is going into the mitochondria as well, in the oxyphil cells as well as in the chief cells. In the oxyphil cells, it has a similar uptake mechanism as of a MEB, and it gets accumulated in the mitochondria. While in the chief cells, choline goes into the chief cells. They get phosphorylated through the choline kinase, which is upregulated in those cells and get converted into phosphatidylcholine, which is a part of the cellular membrane. So it has a dual uptake mechanism, and it has an advantage. We all know that some of the parathyroid glands have a overexpression of a PGP, which can result into efflux of the system maybe during the uptake time. So they can result into a lower sensitivity. In that case, choline would be helpful because it has a dual uptake mechanism. So all the PET tracers which are being used for choline imaging is F18 choline, which is mostly used in all over the world, and it has a half-life of 18 minutes. Imaging time is usually 60 minutes because tracer redistribute from other organ to increase uptake in parathyroid gland. People have also done early 5-minute static images. We have also done initially early images, but we saw that uptake of the choline is better at 60 minutes than the 5 minutes. Or some of the authors have also done the early dynamic images. Apart from that, some of the authors have done the C11 choline. It has also some advantages, but you need to have a on-site cyclotron because it gives lesser radiation exposure, and there is a shorter acquisition time compared to the F18 fluorocholine. Some of the people have also used C11 methionine, though we have not used it, but it gives little bit of a increased noise and poor spatial resolution in compared to the choline imaging. And this is the MIP image where we can see the physiological distribution in the body undergoing fluorocholine image. So as I have told you, the choline is very sensitive for picking up the small parathyroid adenoma. It is one of our first publications where we picked up the very small parathyroid adenoma. Here is a 72-year-old diabetic and hypertensive female with altered sensorium. Patient had elevated calcium and PTH level. Both ultrasound and dual phase MEB was inconclusive. And in the upper two panel, we can see this is the early phase and these are the two delayed phases. We don't see any abnormal tracer uptake apart from normal thyroid uptake, which is getting washed out in the subsequent images. But in choline, when the patient was subjected to choline, we could see a small focus tracer soft tissue lesion in the right prevertebral location at C4 vertebra with a SUV max of 5.5. And we can very well appreciate over here, and it is showing tracer avidity. Patient underwent parathyroidectomy, and histopathology came out to be parathyroid adenoma, and it resulted into normalization of the calcium and PTH level. So we did one prospective study along with Dr. Badada and with my endocrine surgeon colleagues, and we compared the effectiveness of ultrasonography, system EB, and fluorocholine in detecting the parathyroid adenomas in patients with primary hyperparathyroidism. We took around 54 patients where all three preoperative imaging modalities were done, and all the patient underwent parathyroid surgery, and the histopathology was taken as a gold standard for seeing the sensitivity and positive predictive value and accuracy. And we could see that on the patient-based analysis, choline was quite high, having a high predictive value and accuracy more than 96%. And on lesion-based analysis, again, choline showed a high predictive value and accuracy of around 93%. So this is a one case where the upper panel, right, it is a early BB image where the tracer uptake is seen in the both of the thyroid glands. However, in the delayed image, there is a washout, but there is no abnormal tracer uptake. But in the choline, we could see a small focus of a tracer avid soft tissue lesion in the inferior to the this thing, right left lobe of the thyroid gland, and we can very well appreciate over here, which is shining out like any other thing. And patient underwent parathyroid surgery, and it came out to be parathyroid adenoma. So the key finding from our study was that choline was far superior for accurate perioperative localization of parathyroid adenoma. Apart from that, choline was far better than the MEB and ultrasound neck for picking up the small parathyroid adenomas or ectopic parathyroid adenomas or parathyroid adenoma having a near upper normal IPTH values. Choline showed 100% sensitivity, positive predictive value, and accuracy in all 6 ectopic parathyroid glands we have in our study. However, MEB was accurate in only 4 relatively large lesions, but missed 2 small ectopic parathyroid glands, while ultrasound neck failed in all ectopic except one at a tracheoesophageal groove. However, there are certain false positive and false negative with the choline PET, and that results into lower positive predictive value or negative predictive value, like thyroiditis, benign and malignant thyroid nodules, malignant thyroid lymph nodes, or inflammatory lymph nodes or thymoma can result into false positive. Similarly, false negative results can be due to if the hypercalcemia is of a moderate range, PTH is not that elevated, or if it is a multiglandular disease where one or more hyperplastic glands may be missed. A very small size lesion may be missed because of the limitation of the spatial resolution of the PET camera. If the patient is on anti-androgen therapy in a case of a CA prostate, as we all know that the choline was first employed for the CA prostate, and by incidental finding of a parathyroid adenoma, it was employed as a parathyroid adenoma imaging. Patient on colchicine and erythropoietin may have a lower choline uptake, which can result into false negative. And it has been shown even a furosemide used during the scan can result into a lower choline uptake. So what are the things which we can do for taking care of a false positive findings? We can do a dual point time scanning, or some of the authors have also suggested dynamic imaging, where they have shown that the adenoma to thyroid ratio was significantly higher than the lymph node to thyroid ratio, but still the data is not coming, it is evolving, and we need to see before taking a dynamic imaging. Apart from that, we can do the CECT or MRI, and as my previous speaker has nicely described, that there is a potential superiority of the 4D CT. So this is one case where dual pathology of a parathyroid adenoma and papillary thyroid cancer was seen on a fluorocholine and fluoro-DXC PET CT. Here is a 56-year-old woman presented with the epigastric pain and vomiting. Patient had a elevated biochemical parameters. This is the MEB scan. On a planar images, we can see in the early and the delayed images, there is a increased tracer uptake in the inferior to the left lobe of the thyroid gland. On the cross-sectional images also, we can very well appreciate that it is a left inferior parathyroid adenoma. The patient was subjected to choline as a part of our research protocol or a department protocol. At that time, patient showed a intense tracer avidity in the parathyroid adenoma on the left side. In addition to that, patient showed a faint tracer uptake seen in the thyroid bed. So just to characterize that lesion in the thyroid, we subjected the patient to FDG, and it showed that the lesion which was present in the thyroid bed was faintly avid on a choline, but it was intensely avid on a FDG PET, while parathyroid adenoma was intensely avid in the choline, but it was faintly or non-avid on the FDG PET. So patient underwent right hemithyroidectomy for papillary thyroid carcinoma and left parathyroid adenoma excision. So benign and malignant thyroid lesions may show differential FDG and FCH uptake, making the complementary use of both imaging modalities worthwhile in situation with dual pathologies. So it is a systematic review of the literature showing the diagnostic data of a fluorocholine done with the PET-CT, or some of the studies have done it with the PET-MRI on the patient-based analysis and lesion-based analysis. And every study has shown that there was a very high true positive and true negative value when the choline was employed for a parathyroid imaging. So this is the summary of the published English systematic review, where every study has shown that the F-choline has a very high pool sensitivity and specificity, and it provides a high diagnostic accuracy for picking up the parathyroid adenoma. It is because of the greater spatial resolution with the PET-CT, and it has a shorter acquisition time compared to the MIBI, where MIBI may take around 2 hours, while we can do a choline imaging within 4 hours. The effective dose to the patient would be around 1.9 millisievert if choline is employed, compared to 5.4 millisievert if the MIBI is employed. However, there is still lack of standardization for imaging time. Like, we don't know exactly what is the optimal timing. Some of the people are saying 60 minutes is good. And we have also employed in our institute 60 minutes as a optimal imaging time, but some people are saying dynamic imaging would be better, and still dose is not standardized. Apart from that, the problem with the choline is the limited availability and the cost. However, phase 2 Apache 1 study showed that when the choline was used as a second line imaging modality, it leads to cure in 88% of the patients with negative or inconclusive MIBI SPECT studies, and bilateral cervical exploration could be avoided in 75% of the patients. Along with that, the surgical complications were low. Based on that Apache 1 study, now there is ongoing randomized phase 3 clinical trial, that is Apache 2, with the hypothesis that the upfront choline PET-CT would improve the patient care in primary hyperparathyroidism with reduction in clinical cost, offsetting the increased imaging cost. So we are awaiting with interest how it is going to affect the outcome of the patients. So this is a comparison of different imaging modalities, and we can all say it is the studies has been taken from the meta-analysis, and we can very well appreciate choline PET-CT has done very good regarding the pool sensitivity is around 95% on a patient-based analysis, while it is 92 on the lesion-based analysis compared to the other imaging modalities. So this is one case which I would like to show where choline has really made a difference in the management of a patient. Some of you might be knowing about this patient. This patient came to our institute. She was a 37-year-old female patient with a history of a recurrent bone pain and renal stone disease for 3 years in year 2009. Her biochemical parameters were elevated. Patient underwent MIBI scan, which showed right inferior parathyroid adenoma. Patient underwent endoscopic periarterial parathyroid surgery that was done outside in year 2009. However, patient was okay or well with the normal calcium and PTH level, but in 2014, patient became pregnant. At that time, patient had an elevated calcium and a PTH level. Patient underwent second surgery with 3 gland exploration in second trimester on the basis of the ultrasound neck because MEB was not done due to her pregnancy. Histopathology came out to be hyperplasia, but in spite of that, hypercalcemia persisted. Patient was managed on medical treatment. She delivered a normal baby. And we can see from this chart, during that period, her calcium, IPTH, alkaline phosphatide, and all this thing, they were deranged or they were elevated. In the March 2015, patient underwent ultrasound neck, which was normal. Dual phase MEB scan was done, which was again normal. We didn't know what to do and all this thing. Then at that time, we subjected the patient to the F choline. In the MIP image, we can see there was nothing abnormal in the neck, but incidentally, we found a focal tracer uptake in the right side of the chest wall. And I personally discussed with Dr. Badada without knowing its significance, and it showed on a cross-sectional image, there was a small subcentimetric nodule which was showing tracer uptake. Patient underwent repeat MEB of that area, and again it showed the uptake. Ultrasound guided FNSC was done, and it showed parathyroid nodule over there. So third surgery in October 2015 was done with the help of a gamma probe. Parathyroid tissue was taken out, but hyperparathyroidism still persisted with the elevated calcium and PTH. Patient again underwent fourth surgery in the form of a sectoral mastectomy, but in spite of that, hyperparathyroidism persisted with the calcium and PTH levels again elevated. Finally, the patient underwent fifth surgery in March 2017 in the form of a subcutaneous mastectomy. Histopathology showed that multiple parathyroid nodules were present and termed as a parathyromatosis. And after that, patient is well in her follow-up, and her calcium and PTH levels are normal. So it was a post-endoscopic periareolar parathyroidectomy resulting into seeding into breast tissue with intractable hyperparathyroidism. So what is the algorithm for a parathyroid imaging? First line, as everybody is agreeing that it should be either a dual tracer subtraction scan in the form of a MEB and iodine, which normally now not being done, and iodine is not available in India, along with the neck ultrasound, or other is a technetium dual phase scans. Dual phase means the imaging is done at 10 minutes followed by imaging at 1 hour or 2 hours along with neck ultrasound. If it is negative, the second line imaging can be F18 fluorocholine. If choline is available as a C11 choline, that can be done, or 4D-CT. If both are inconclusive, we can go ahead with the C11 methionine PET-CT, 4D MRI, neck ultrasound with FNA, that is a focused ultrasonography, and PTH measurement or selective venous sampling of a parathyroid hormone. So do we have any role as a choline imaging in a parathyroid carcinoma? We don't know exactly, but only 2 or 3 cases have been reported. One case we have also reported from our institute. We all know that there is a significant hypercalcemia and high PTH levels, but there is no specific biochemical features that allows differentiation between benign versus malignant parathyroid adenoma. Ultrasound may show features which can suggest parathyroid carcinoma, like larger lesion size, irregular lesion borders, heterogeneous and decreased echogenicity, all these things. And maybe can show a higher retention levels and an increased tracer uptake compared to the benign lesions. F-choline PET-CT has also been employed, and we have carried out one study which has been published to detect the minimal invasive parathyroid carcinoma. And we all know that the FDG PET has a definite role in detecting the loco-regional and distant spreading, because the parathyroid carcinoma has a less well-differentiated lesions, which can be very well appreciated on FDG PET. So I would like to show one case which was published from our institute. Here is a 56-year-old woman presented with the elevated PTH and calcium. Parathyroid surgery was done a year back for suspicious parathyroid adenoma on the basis of a MEB and ultrasound. However, histopathology came out to be parathyroid cancer with the high Ki67 index with vascular and capsular invasions. Patient was asked to go for a redo surgery at that time, but she refused. And 1 year later, she presented with the left-sided neck swelling with the elevated PTH and calcium level. And on the right side of the images, this is the early image and this is the delayed image. We can see there is a tracer uptake in the lymph nodes on the left side, in addition to the thyroid gland. And then in the choline PET, we can see this is a MIP image. There is a tracer uptake in the left cervical groups as well as in the high mediastinal group. And on the cross-sectional images, we can see there are the various lymph nodes which are choline avid. And patient underwent left hemithyrectomy and modified radical neck dissection with the histopathology coming out to be parathyroid carcinoma infiltrating into the adjacent soft tissue and skeletal muscle with the multiple lymph node metastasis. However, 8 months later, patient again presented with the breathless and neck pain. This time patient had a FDG PET in addition to F choline, and we can see there were intensely avid lesions which were present in the parenchymal and the pleural post lung nodules. And in addition to that, there were mediastinal lymph nodes over there. In addition, the patient on in a brain showed a hyperdense lesion. We didn't show any uptake on FDG. However, it showed a intense uptake on the choline PET, and it was suggestive of a meningioma and confirmed on MRI. But this time, choline showed a moderate uptake, and probably it was due to dedifferentiation during the first image to second image, and that has led to the decreased choline uptake. With that, I would like to thanks for the patient hearing, and I would like to thanks Professor Badada for giving us a unstinting support in our, what I mean to say, he is always there to support us and guide us. Thank you very much.
Thank you, Dr. Sood. Very lucid presentation and elucidating very interesting cases and very precisely given the information that how choline PET-CT is important in the management of various parathyroid disorders. And as you mentioned, through 2-3 interesting cases, and we know that actually the choline PET is savior in the lot of patients when we are, especially with relation to the ectopic parathyroid gland, as well as if we are unable to localize the parathyroid gland. So choline PET-CT is, at least in our institute, is one of the important modality. Of course, the first line is ultrasound and the MEB, but if out of these two imaging are not coinciding with the lesion, then we'll ask for the choline PET-CT. So with this comment, I'll open for the question and comments from the house.
Dr. Josna, could you please give your comments, madam? Madam has some experience with choline in Apollo Hospital, Hyderabad. You have to unmute yourself. Madam, you have to unmute yourself, Dr. Josna. Have to unmute her.
Okay, I think Dr. Joseph is where I have make few more comments. So another issue nowadays we are facing with the CKD, MBD and hyperparathyroidism, tertiary or the severe secondary hyperparathyroidism. And our initial data analysis shows that choline is indeed doing a good job when this gland size is not much and the foregland hyperplasia is there. So the choline PET is playing a very good role in localization also. In that patients with the severe secondary hyperpara or tertiary hyperpara patients also. So in nutshell, this choline PET-CT is useful not only the utopic, ectopic, as well as the severe secondary and tertiary primary hyperparathyroidism. Yeah.
Okay.
Yes, sir.
So due to lack of time, shall we move on to the next session, sir? Yeah. So we'll start the next session. The next session will be a case presentation, and I invite the chairpersons, Dr. Tushar sir, who is the professor and head of endocrinology from KEM Mumbai. And then I also invite Dr. Dalapati, who is the professor of endocrine surgery from MMC Madras. Dr. Pradeep is a senior endocrine surgeon from Calicut Baby Memorial Hospital. Dr. Sirisha Kusuma is a senior pediatric endocrinologist from Rainbow Hospital, Hyderabad, and Dr. Paul Sir. Paul Sir is the professor and head of Department of Endocrine Surgery from CMC Fellows. So we will be sharing. Just a second. We will be discussing 4 cases. I hope everyone can see the screen.
Yes.
So these cases were managed in Apollo Hospital, Hyderabad. Myself and Dr. Samantha, who is an endocrinologist, will be presenting 4 cases. So we will start with the first case. First case, a 45-year-old female presented with hypercalcemia to our clinic. She had a history of parathyroidectomy, which was done 3 years back. She also had menorrhagia because of fibroids. Her history and labs prior to the first surgery, she's a known hypertensive on amlodipine. Her routine health checkup showed up that the calcium was high, 13.5 milligrams per deciliter, with a parathyroid hormone level of 630 picograms per ml. And her ultrasound abdomen showed bilateral renal calculi and renal cysts. The localizing studies that were done were ultrasound neck, which showed a 3.5 into 1.7 centimeter right inferior parathyroid adenoma. She also had bilateral subcentimetric benign thyroid nodules. A CT neck was done there. She showed a right inferior parathyroid lesion. The first surgery note, she underwent a right inferior parathyroidectomy in August 2018, and the PTH decreased from 656 to 36 picograms per ml the next day. And the serum calcium also decreased from 13.5 to 9.2 milligrams per deciliter. And the biopsy was right inferior parathyroid adenoma. At this point, she was kept on follow-up. Lab 6 weeks after the surgery showed the calcium to be 9.8 milligrams per deciliter. And the labs after 1 year showed that the serum calcium went up to 10.4 milligrams per deciliter. When she came to us 3 years after the surgery, the calcium was 11.7 milligrams per deciliter with a PTH of 180, and the serum creatinine is 0.8 milligrams per deciliter. Meanwhile, during this course, her daughter also had recurrent renal calculi, and she herself got checked, and the calcium was 11.8 with a PTH of 160 picograms per ml. I request the chairpersons, Dr. Bandarkar sir, can you please run us through these reports and give your valuable comments?
Good morning, everyone. Thank you very much for this opportunity. And so I think going through the case, can we come to the first slide? So it
Yes,
clearly shows that it's a case of primary hyperparathyroidism, which has come with a clear presentation of hypercalcemia with it's a PTH dependent hypercalcemia. And the patient has got bilateral renal calculi. And the most important part there is renal cysts. So when we really look at this as an endocrinologist, then first thing to our mind, definitely we are not missing any hyperparathyroidism. We have it, but if you have renal cysts, then you need to think of other syndromic PHPT, where renal cysts have been described in HRPD2 syndrome, where around 40 to 50% of the patient can come with renal manifestation. We obviously look at other syndromic association like a jaw tumor kind of syndrome. And since she's a female, we look at uterine lesions. So ultrasound can be traced to look at a uterine leiomyoma or a benign endometrial hyperplasia or so. So when you look at this clinically, I would keep that in my mind and then take it further. And especially this patient has come ahead with recurrent hyperparathyroidism, then we need to have then the differential diagnosis can go into maybe recurrent kind of hyperparathyroidism there. If you talk of HRPD2 syndrome, then there's a chance of 20% of parathyroid carcinomas which are there. So especially if a recurrent kind of adenoma is there, we need to think whether it was a locally invasive kind of atypical adenoma or something. And that needs to be kept in mind. And maybe rarely parathyroidmatosis can be there. This would be from my side.
So we did a bone mineral density with a Z-score of spine showing minus 0.1, hip is minus 0.1, forearm minus 4.1, and 24-hour urine calcium with a urine volume of 3,350 and a urinary calcium of 282 milligrams per deciliter. Dr. Bandakar, can you please comment on this BMD and the urine labs?
Sure. So there is BMD clearly shows that obviously this looks like a premenopausal lady, and hence Z score has been asked for. That's a usual standard of care which needs to be thought of in BMD. In premenopausal females and males less than 50 years, we use Z scores. And if they are less than -2, then they are low bone mass. And with an presentation of hyperparathyroidism and hypercalcemia there, this is just of osteoporotic kind of bone. And the forearm BMD is affected more, which is seen classically in hyperparathyroidism. If you look at urine calciums, they are definitely higher, which suggests that there is hypercalciuria also there.
So with this labs and past history, we have run through our exercise of looking everything in detail. Now, can I ask the surgeons, Dr. Paul and Dr. Dalapathy and Dr. Pradeep, to give your comments on how you would proceed with the case of this recurrent hyperparathyroidism?
Yeah, when we have recurrence, thank you for the case. There are mostly three scenarios. Either we have damaged the gland and there's a residue, or part of it may not have been excised. The second is hyperplasia. Here, of course, the biopsy is adenoma, when more likely there may be a double adenoma that we're dealing with. What we find is more common local recurrence than either double adenoma or missed hyperplasia would be the causes. Here, very interestingly, as Dr. Tushar pointed out, you have renal cysts and uterine fibroids, which are a condition of HPT-JT syndrome. And it's very important to realize that the jaw tumor, though part of the original description, is seen in only 30 to 50% of the clinical cases. So it's not a necessary condition for the mutational profile, which we know is the CDC73 gene and deficient production of the parafibromin. So it will lead to a more sort of aggressive neoplasm that may proceed to atypical adenomas we've seen here and cancer in 15 to 20%. So this possibly is a genetic case. So I just would like to query, have we done gene analysis before we plan?
For this patient, we have actually asked for, sir, but the family, they are not very keen on pursuing it further. Yeah, due to personal reasons.
When it comes to recurrence, when we have to re-image to see where the recurrence is coming from, and we go through the standard protocol, the bottom line is we would definitely like to have some idea of where the recurrence is before we go in. I think that's the bottom line. So go through the standard would be again ultrasound, maybe if we have choline PET and 4D CT, depending on your choice. And the last option would be venous sampling, but we would like to know before going in. Yes, that's all I have to say.
Dr. Dalapathy and Dr. Pradeep, can you please add on?
As Dr. Paul said, actually, this gives bring an important point of
Dr. Siddharth, can you hear me?
Yes,
you hear me?
Yes, sir.
Yeah. Apart from what Dr. Tushar and Dr. Paul has said, since the patient has a recurrent hyperparathyroidism, our strategy will be to reassess and find out the cause of this hyperparathyroidism, keeping in mind the issue of multiple endocrine neoplasia and familial syndromes in view of the other lesions found in the kidney. But one thing I want to know is to go back and look at the surgery details. What kind of surgery was it? Just now we had discussed a case by Dr. Ashwini where patient ended up with a mastectomy following a parathyroidectomy because of the parathyroidomatosis in the breast tissue. What kind of surgery was initially done? Was there a capsular breach? That becomes also an important thing to assess in this case.
So the slide review was done at another center, which showed features suggestive of parathyroid adenoma. The comment was, as the above biopsy does not show any features of malignancy, possibility of recurrence of incompletely excised adenoma can be considered. So the patient's relative, they had this photo of the tumor. As Dr. Pradeep was mentioning, there's a breach in the capsule. The tumor was taken off piecemeal. And this is the Sesame B. Dr. Dalapati, can you please comment on this Sesame B image of this patient?
There is still a tracer is there in the late images also. So there is a residual disease in this after 60 minutes or 120 minutes of washout. So there is still a persistent disease in this case, as Pradeep has told, and your histopathology also. So there is very important that we must not breach the capsule, and it has to be excised in toto. That is very important. As a surgeon, we need to emphasize more on that.
I also agree. Very important point. You don't have the original image, is it? The pre-first surgery. And Pradeep's question actually was, what is the approach that was used? Was it minimal invasive?
No, sir. It was a standard conventional. It was
and
a
the size of the scar. How was the size of the scar?
Around 7 to 8 centimeters, sir.
Oh, so it's a big one. It's not.
Yes.
Okay. Then it's surprising, because only one point I would like to make is, when we are very enthusiastic to do minimal invasive, I've seen this happen to a junior, as you make a small incision for a large adenoma, and then you struggle to get it out and usually rupture the capsule. That is known to happen. So you must always give preference to taking out an intact lesion and not worry about the size of the scar. That should be number one priority, especially when you are learning.
So since it was a recurrent tumor, we went ahead with a 4D CT scan. The CT scan showed an oval soft tissue density measuring 9 into 12 into 14, awaiting lower pole of the right lobe of thyroid, which was concordant, was showing the same right inferior parathyroid, likely recurrent parathyroid adenoma. She also had multiple subcentimetric nodules of varying sizes in both lobes of thyroid, which was there earlier and is benign. The ultrasound next showed the right inferior parathyroid. So can I ask the surgeons, how would you go ahead with regards to the surgery, and what would be your planning for this patient? Dr. Pradeep, sir.
Yes, in this case, you can see that there is a recurrence, obviously, and we have found out the cause of this recurrent hyperparathyroidism. So that part has to be taken care of, excised, and I would certainly add with this during surgery intraoperative PTH also, based on if the facility is available in a particular center. And since he has got multinodular goiter, I will also go in for an FNAC and see what is actually there in the thyroid, and take a call on the thyroid based on the patient's preference on the thyroid nodule if it is benign.
So when we went ahead and did the FNAC, sir, it was benign and it was all subcentimetric nodules, and the patient wanted to retain the thyroid. So we said okay with it. And we did a cervical exploration and did the right inferior parathyroidectomy. We explored the normal left inferior and left superior parathyroid glands. Our IOPTH decreased from 160 to 25 picograms per ml, 15 minutes post-excision. The frozen was also a parathyroid, and current 5 months follow-up shows a calcium of 8.8 milligrams per deciliter. Biopsy came as atypical parathyroid adenoma. Any comments about this atypical parathyroid adenoma? Any specific follow-up, or could you please comment?
It probably represents more proclivity to develop a carcinoma over long term. So this is what none of us are very clear what exactly it means, but probably a higher rate of recurrence as we have seen. Just also querying the intraoperative findings, did you find any evidence of parathyromatoses, or it was just a single?
It was lesion? It was a single lesion, sir. It was a single lesion, no parathyromatosis.
Okay, so when you're going back in for this situation where you've seen a ruptured gland, then probably the surgeon has to also make a careful look around that area because they may be seeding in the fascia. So while taking out this tumor, all the surrounding fascial capsule and the adjacent soft tissue in the paratracheal region should be removed, considering that some seeding may still cause problems in the future, as we saw in that very illustrative case of the breast approach. So that's the only point I'd like to add.
Dr. Siddharth, one thing I want to add is regarding exploring the opposite side in this patient, especially when we are combined with the intraoperative PTH. And if it has shown a significant fall, as in your case, there's always an issue whether we should explore the other side. Basically, I would not have explored the other side, especially if the patient doesn't want a thyroidectomy.
Yeah. Any other comments, Dr. Dalapati?
As Dr. Paul said, actually, we need to have a close follow-up because there was a breach in capsule in the first surgery. So second surgery, we have removed, the PTH has fallen as in the previous surgery also. So we need to have a close follow-up because of two reasons. One is the second surgery because of the capsular breach as well as an atypical parathyroid adenoma. So both of these warrant a close observation and follow-up of this patient.
One comment I would like to give, Siddharth.
Yes, sir.
So since it looks like a genetic case and we short of genetics, what we do is we look for a familial screening and ask for calcium and phosphorus of the family. Yes. So we had a similar HRPD2 case where her brother and sisters both were involved. The sister was having severe symptoms, but the brother did not have any symptoms. So it was an asymptomatic hypercalcemia. And then we did a familial segregation analysis for genetics for parents as well as for the kids. So the father turned out to be mutation carrier and positive to that, but even at 50 years of age, he did not have any hypercalcemia. So what we do as a policy is for every younger patients less than 40 years or something, we would want to have a familial calcium screening, which becomes very practical aspect of doing it.
We have done the calcium for her two daughters and one son, sir.
Yeah.
Her daughter had increased calcium, as I have said, and we did she also had a single lesion, and she also had a ovarian tumor, which was excised and it has recurred. So this is sitting in terms of hyperparathyroidism jaw tumor clinically.
Yes. And that's why the atypical adenoma also fits into that.
Okay. Yeah. So we thank everyone. We'll move to the next patient. The next case, a 3-year-old girl born out of second-degree consanguineous union. She had global developmental delay and prior genetic diagnosis of Seckle syndrome. She presented with 6-month history of difficulty walking, multiple joint pains, and irritability. Initially treated as juvenile inflammatory arthritis with oral steroids, and serum calcium was performed as a pre-treatment for infliximab therapy. And these are her labs: a calcium of 19.5 milligram per deciliter, phosphorus 1.5 milligrams per day deciliter. Parathyroid hormone is 789 picograms per ml. Dr. Sirisha, who is the pediatric endocrinologist, ma'am, can you please run us through these labs?
Yeah, thank you, Dr. Siddharth, for the session. When you look at the labs, the second slide, it's pretty obvious that we're dealing with hyperparathyroidism, whatever might be the underlying etiology. But when the child presented to us, this is when the child presented to us, she came to us with a calcium report. But prior to that, there was a huge 6 months history of a lot of struggle. She had a post-COVID joint pains, rather, and difficulty walking and kind of bedridden to the point, so pains were so severe that she was bedridden. And initially, it was thought that post-COVID joint pains, and then later she was referred to rheumatologist by the consulting pediatrician. What might have happened was that later on, when we are going back and thinking what could be the reason that it was thought as an inflammatory arthritis, she had extensive osteopenia. This high PTH was ravaging the bones, and this extremely high serum calcium is leading to extraskeletal deposition of calcium crystals in the joint capsules, in all of the small joints of her hands and feet and ankles. That is leading to a physical, clinical presentation of arthritis-like picture. And she was treated with steroids, oral prednisolone for almost 6 weeks. As there was no response, she was prepared for biological treatment. And till that point, unfortunately, no calcium was done. When they did the calcium, the initial was actually 21, and then repeat came similar to that, 19.5, and with extremely high parathyroid hormone levels. So this is when actually we saw the child the first time.
Yeah. So she was treated with IV hydration and pamidronate. The child was started on cinacalcet with minimal response. He underwent a sesame B scanning, which didn't show any focal lesion. She also had an ultrasound neck, 4D-CT, but there were no focal lesion, as Dr. Dalapathy has mentioned earlier, no role for any imagings in neonatal severe or a late presentation even. Her family screening revealed milder abnormalities in both the parents. Mother had a calcium of 10.8 milligrams with a PTH of 93.8. Father had a calcium of 10.4, PTH of 88.3 with hypocalciuria, urine calcium creatinine ratio less than 0.02. He also complained of recurrent episodes of pancreatitis. Younger sibling has calcium of 11.8 milligrams with a PTH of 103 picograms per ml with a pending genetic reports. Dr. Sirisha and Dr. Tushar, can you just give us your comments?
Yeah. So I think it's a classical case of neonatal severe hyperparathyroidism, where the parents are involved and with the heterozygous mutations, and mostly hence the child would also have a kind of homozygous mutation, which is present in an earlier age group with severe hypercalcemia. And the best treatment would be to medically stabilize and immediately go for surgery, which is what everybody would agree with it. And we know that it's going to be stormy course. It's going to be a difficult kind of management. Localizing a surgeon who could do that good job at such a younger age is another issue. Our experience with this is not all that great. Maybe 1 or 2 patients we have been able to manage as a team, but with poor follow-up. So I think we would say, I mean say that it's very difficult to really manage this kind of case at such a young age.
If I may add, sir, so the only actual odd thing that was the child presented at the age of 3 years.
Yes.
I was searching if there was any other case report of such a delayed presentation. This was a novel mutation, though. So the severity might be different, but so far I could not.
No, so there is a data on that. And in fact, we have one patient who has come in childhood. So we've looked at our data of our childhood PHPTs, where we found 40% prevalence of genetic mutations in MEN1, CSR, and HRPD2. So one of the patient who had CSR mutation came at around 7 years of age with a homozygous mutation and came with a typical kind of sporadic symptomatic hyperparathyroidism. So there are few cases which are reported where though the mutation is homozygous, but they may not present in infancy, they will present post-infancy. And it's quite rare, but these things are known. It's all differential sensitivity of those calcium sensing receptors being, the function being affected variably and kind of expressed variably, which is seen.
Yes, I'd just like to add to that. We have a very rare case. Unfortunately, we couldn't get the genetic screening done, but it was a classic 2 siblings coming at 5 and 3 with hyperparathyroidism. The 3-year-old was similar to this, was quite affected, but still mobile. The 5-year-old was a complete physical and mental cripple. They literally brought him on a wheelchair and I mean on a bed. So we operated on both, found hyperparathyroidism, hypoplasia. This is many years ago. The 5-year-old was too far gone. There was hardly much improvement, even though the calcium came down. But the 3-year-old had significant improvement. So that was a very rare case of siblings. And the parents had FHH on evaluation, but we couldn't do the screening at that time. Thank you.
Thank you.
We did a reanalysis of the genetic testing, which showed the homozygous missense mutation at exon 70 of CSR gene. It's a novel variant and is described as deleterious by bioinformatics algorithms. So I request the surgeons to talk about the surgery plan and what would be their approach. Dr. Dalapati, sir.
This is that. Actually, we as such now have 6 cases of neonatal severe hyperpara we operated. The one was at 15 days we could be operated at the 15th day of birth, and the latest was by 5 years. Though the 5th year we operated was detected at 3 months of age. At that point of time, nobody was ready to operate, so the baby was kept in with the bisphosphonates, and later on cinacalcet 90 milligram was given. So the older one was at 5 years when we operated, and the younger one was 15 days, and less than 1 year we operated 4 cases. One at 15, pardon? One was 15 days, another was 1 month, another 3 months, and again another 3 months. So all these cases, all the imaging were negative, both ultrasound or system EB, as I already told. And intraoperatively, all the 4 parathyroids we could find as a normal sized parathyroid, crystal clear one, devoid of fat in the normal locations. And one baby had a supernumerary parathyroid over the trachea. And one baby, we could find only 3 parathyroids, the other one we could not find. So we need to do a hemithyroidectomy on the side where the parathyroid gland was not found. So in spite of that, the PTH didn't fall. Actually, one case we had a failure of this surgery in one of the case. We could not find though the baby could be controlled with cinacalcet in the post-operative period, and it's doing fine. The boy which we operated in 2012, now he is going to school. He is going to finish his school. He is still under follow-up. All out of these 6 cases, we did this genetic testing in 5 cases. Out of those, 2 cases had a novel variant of this one. And the thing is, we also combined transcervical thymectomy in all the cases, because we don't want to miss supernumerary parathyroids, which is we extrapolated as in a secondary hyperparathyroidism, where supernumerary parathyroid could be found in 10 or 15% of cases. So we did a thymectomy also in all these cases, along with the parathyroidectomies, and all of them survived except one patient which died 1 month after surgery because of associated pulmonary hypoplasia was there. So that was the one case.
So we went ahead and did a total parathyroidectomy plus cervical thymectomy plus autotransplantation in the left forearm. Intraoperatively, the PTH decreased from 616 to 73 picograms per ml post-excision after 15 minutes. We did a frozen of all the 4 parathyroid glands, and it confirmed to be parathyroid in origin. Post-op day 1, her calcium came down to 9.1 milligrams per deciliter. However, on second post-operative day, the hyperparathyroidism persisted. Her PTH was 82 picograms per ml, which was of concern for us. 3 months later, her calcium remained high, and it was 13.7 milligrams per deciliter with a PTH of 169 picograms per ml. The bone pains and the mobility issues continued. Currently, the child is on cinacalcet 30 milligrams per day and IV pamidronate of 0.75 milligrams per kg weekly. That is helping her bone pains and mobility. She's also on oral phosphate 30 milligrams per kg per day in 3 divided doses. Because the endocrinologist wanted to keep the phosphorus low. Later, the latest PTH now is 91 picograms per ml with a calcium of 12.7. Can I ask Dr. Sirisha and Dr. Bandarkar sir to give their comments how to manage this patient medically now, and also the surgeons later for further management. Dr. Sirisha?
Yeah. So medically, if you think of it, so our experience is limited, as I told you, but based on review of literature, then we know that if it's a heterozygous mutations in this familial syndromes, then the cinacalcet may really work there. But NSHPT, the effect of these drugs are not that good. And so it's more of a surgeon's role to really take out as much as parathyroid as possible, because what happens is that it's a kind of atypical hyperparathyroidism, where it's shown that if you remove as much as parathyroid tissue as possible, you can push the patient into hypoparathyroidism. And that's the only way in which experts, Marx is a person who has worked quite a lot in this area from NIH. And he suggests that remove as much parathyroid as possible. And maybe even the forearm implantation, where the parathyroid tissue is there, that can also maybe sacrificed. This is my suggestion. It's not based on experience. It's based on reviewing and reading the literature.
Okay. Dr. Sirisha?
Yeah, I agree with Dr. Tushar there. The main problem post-operative was building up the bone mass again and taking care of the bone pains and making the child a little more mobile than pre-operative situation. So that was becoming an issue, and the high PTH was not helping. So till we figure out what would be the more definitive course, so we discussed the case with the pediatric bone team in BC Children's, and in agreement we thought like pamidronate 4 weekly, a small dose, can help in locking the calcium in the bone. Because we tried a little bit of calcium supplement, but that shot up the calcium to 19. So we cannot completely eliminate the calcium from the child's diet, or still aim to build up the bone mass. We need to send some calcium into the bones. So we thought allowing a little bit of diary and making sure that the phosphorus is not too low, making sure that the phosphorus is normal. A tiny dose of pamidronate definitely would help in locking the it actually helped. It increased the cortical thickness. It made the child a little more mobile and very, very, very less cranky. But we're still waiting for the definitive management, as kind of a temporary treatment.
Yeah, Dr. Paul, sir, can you give your comments about, how to go about now that we are sure that we removed the 4 normal and the thymus didn't show any parathyroid, ectopic parathyroid. So where would this parathyroid be and how to go about?
Just remind me, what was the time duration that you picked up the recurrence? She's
a sort of like a persistent disease, sir. The next day, PTH was 80. So we were expecting it to go down. So we removed all the 4 parathyroids. But since it didn't go on the next day, so we were sure that somewhere the disease is hiding.
Yeah, so if it didn't go down, then it's unlikely to be the transplanted tissue that's causing it. So that means you still have disease in the neck. Now, there's not much experience on reoperation in neonatal, but basically in neonatal, once they're diagnosed there, we don't even do any imaging. We just go straight into the neck. And as you said, do the foregland and thymus. And one thing, as we say, the secret of pediatric surgery is actually the 2 things. It's very easy to see everything because there's no fat. So visualization is not a problem. In fact, it's beautiful to see the young neonatal parathyroid so clear without any obfuscation that we see in the adult fat.
True.
So that, I think, is usually clear at surgery. So if we're convinced that there is disease in the neck, we would just have to go back in, I would think. Now, in the thymus, how much of a thymectomy was done? Do you think there may be still residual thymus that you can take out? That's one issue. The second is there are sometimes the supernumerary glands, or the glands may be mildly lobulated. Usually, although in neonates, usually it's very clear, like a matchstick head, beautifully almost normal size, as the allopathy said, is not enlarged like we see in adults. So that is not usually an issue. So probably you're dealing with some supernumerary or glandular excess which has been left, which if the condition permits, would need a re-exploration. And now, I don't think imaging is going to help in any of these. And the high radiation ones like 4D-CT and choline PET are not indicated in this age group. So really, it's going back. If you've got a clinical problem, you just have to go back into the net and use the IOPTH to guide you at that time. That's all I can think off the top of my head, but I've not had this situation. So the others can.
Any role of venous sampling, sir?
Dr. Siddharth?
Yes, sir.
One thing, see, I have had two cases of neonatal severe hyperparathyroidism, all diagnosed at the age of 3 months to 6 months, but they came to surgery at the age of 1 and 1.5 years. But unfortunately, by this time, they had renal stones and all those issues. And they were always the reference has been a delayed reference. But from the surgical side, during surgery, when you look at the intraoperative PTH, if you are adding intraoperative PTH, it usually comes to the low normal because you're removing everything from there. It doesn't reach the, it should be below the 70s what you got in this patient. It reaches the low normal. It goes around 10. In both the case, I had values like that. That shows that the neck exploration has been more or less complete. And now if that has not gone to that level, in spite of doing the best removal of all parathyroids, proving by frozen section and removing the thymus, and if it has not gone to that level, better not auto-transplant into the forearm, because that eventually will go on adding more PTH into the circulation. So in such a scenario, you need not add put into the forearm muscle. And as Paul sir said, it will be very good to look at the thymus, how much of it is remaining, and if we can remove that also. And if the PTH has not fallen into the low normal, look at the carotid sheath in such opening the carotid sheath and exploring along those lines during the initial surgery may help us to take the PTH further low down.
Adding to that, Siddharth.
Yes, sir.
Not only exploring the carotid sheath, we need to look in the retroesophageal as well as the tracheoesophageal groove. And maybe as an extreme step or whatever it is, you can combine a thyroidectomy to rule out an intrathyroidal parathyroid also. If it is, I am talking about theoretically, but still because we did because if you are told that all 4 parathyroids have been removed, if only one has been missed any side, then you can combine a hemithyroidectomy on that side of where which have been left out. That you can have an option also.
Yes.
In this case, removing the parathyroid tissue in the forearm and then reassessing the patient also might be helpful. I mean, my personal opinion, because already some functional parathyroid tissue is there in the forearm, which is contributing to her, to this child's hypercalcemia. So, and that is easily approachable also because it is in the forearm. You can remove it and then see how much the calcium drops, how much the PTH drops in this patient.
Okay.
So that actually, we didn't do any auto transplantation in any of our case. We did a total parathyroidectomy. That was to make the baby a parathyroid. That's what our intent before we proceeded to surgery. Because we discussed before in the first case itself, discussed with our endocrinologist and everything, they were happy to treat a parathyroid baby rather than a persistent disease or a whatever it is. So we didn't, that is one thing which we need to take care of, remove the auto-transplanted one and see also.
Okay, sir, due to lack of time, we move on to the next patient. Dr. Samantha is an endocrinologist. She will be presenting the next patient. Dr. Samantha.
A very good morning to our chairpersons, participants, and organizers. I'm Dr. Samantha, an endocrinologist practicing at Apollo Hospitals, Jubilee Hills. I'll just be going through a couple of cases that we treated at our center. So the first case is a 43-year-old gentleman who had a screen-detected hypercalcemia. He was an IT professional and underwent yearly checkups. A screen just showed a hypercalcemia initially, which was brought to our attention. Going back historically, he did have a vague history of bony pain and some subtle memory loss. There was a history of renal stones. He did not have any other comorbidities. Family-wise, His sister had a history of renal stones in the past, but her calcium and PTH levels were found to be normal. So the initial labs showed a calcium of 11.5 milligrams per dl. The PTH was 99 picograms per ml. Phosphorus was 1.5 mg per dl. The creatinine was 0.8, vitamin D was 28, and prolactin was 12 nanogram per ml. Going back, even his reports from about 3 years ago showed calcium values of between 10 to 11 milligrams per dl. When he came to us, he had a calcium spot urine report with him, which was about 30 mg per dl. At this point, Dr. Tushar sir, can you tell us your comments about the utility of calcium spot urine ratio in this situation?
Yeah, so calcium spot urine ratio, it's more easy to be done and it's less cumbersome as far as 24-hour urine calcium is concerned for our practicing endocrinologists like us. So we look at that. And in case of, we usually get symptomatic kind of hyperparathyroidism where there is hypercalciuria. And there, I think it doesn't make much difference if you're using a spot calcium by creatinine ratio because it's going to be elevated. But now we see more and more of asymptomatic PHPTs and maybe FHH where the differentiation needs to be there. So there, we've seen that it doesn't do that well. And we might have to resort to those 24-hour urinary calciums and urine creatinine to be very sure whether hypercalciuria is there or not. Around 20% of overlap of cases of FHH and versus PHPTs are seen approximately. 80% you'll be able to do a good job, but you may not be good with 20% that you will require to have additional kind of evaluations. That's a practical way to put it. We still use it, but we need to be aware of those milder cases where you may get normocalciuria or hypercalciuria even in case of FHH also.
Thank you. Going on, the DEXA showed a Z-score of -2.1 at the spine, -0.9 at the hip, and -2 at the radius. Going on to the localizing studies, ultrasound neck showed rather small 0.4 into 0.7 into 0.8 centimeter right inferior parathyroid lesion. I request the surgical chairpersons, Dr. Paul, Dr. Pradeep, and Dalpati sir to give us their valuable opinions about this particular image here. Paul sir? Going on to further imaging modalities.
I would like to add, Dr. Hello.
Yes, sir. Tell me, sir.
Yeah, this ultrasound showing a very small parathyroid, and in such a situation, always you should think about hyperplasia because it may not be a single gland disease because too small an adenoma. It's actually, to say an adenoma itself, it will be difficult. Even the pathologist, if you get a 0.8 centimeter gland, will find it very difficult to tell whether it's a hyperplasia or adenoma. In such a situation, always you should remember that either this may not be the single lesion, there may be many other lesions, or you're missing the original lesion which is causing the problem. So you have to do further investigations and localize the disease.
Thank you. So going on with further investigation, we did a system AB, which showed a doubtful right inferior lesion. This was reported as a right inferior parathyroid. In comments from our chairpersons about this images, sir?
Actually, there is some tracer retention is there in the right inferior lobe of the thyroid, actually, but not great. But after you tell in the ultrasound, yes.
So now what we have realized that if the lesion is around less than 1 centimeters, then these functional scans don't really play that good a role. So maybe a technetium maybe is a function of a mass of a parathyroid tissue, depending on the level amount of mitochondria there. So we've seen more than less than 1 centimeters are not really picked up by MEBs. Hyperplastic lesions are not been picked up by MEBs. And it's more of our bigger tumors which are picked quite easily with MEB. And maybe that's where choline has an advantage over MEB is what in our practice, and we've shifted to 4D CTs and 2D CTs to reduce the radiation now to pick up the small lesions.
May I make a comment if permits me? If
yes,
you permit me.
Please tell us.
Okay. As far as nuclear medicine imaging is concerned, definitely MIBI has a limited resolution, and normally we don't pick up a very small lesions. But in a MIBI, we always do a SPECT CT, and where we can pick up anatomical lesions along with the tracer uptake in that. And in the most of the cases, we will be able to pick it up as smaller lesions also. So that is what I would like to comment upon that. Thank you.
Thank you. Dr. Tushar sir, could you tell us what we would like? I mean, what would be the sort of next step in proceeding with localization or management for this particular patient?
So the patient is symptomatic, right? With mild bone pains and
yes,
certain memory loss.
Renal stones also. Renal stones, memory loss, and bone pains.
Yeah, so there are some symptoms there. We usually go ahead with, so we do MIBI SPECT only, but yes, we don't really pick up maybe our setup and other part. We don't pick up lesions less than 1 centimeters quite well with MIBI SPECT, and we shifted to 4D CT scan, and we've got a good amount of experience with that, where we have picked up sub-centimetric lesions quite well localized in the surgeons. Then it's easy for the surgeon to remove the lesion. In such cases where you don't localize, then we send us to surgeon who tries to look at multiple glands and then try to remove it. That's a different story. But we would use 4D CT to look for imaging evidence of hypervascular lesions. We typically use those early arterial enhancement characteristics of more than 130% compared to the basal scans. And a lot of times we are able to pick up lesions, mild asymptomatic PHPTs or mildly asymptomatic PHPTs with 4D CT scans.
Thank you, sir. So we discussed the options of doing a 4D CT versus proceeding for 4-gland exploration, keeping the hyperplasia angle in mind, sir. The patient decided against a 4D CT and preferred to proceed directly to surgery. Would our surgical chairpersons now comment about the surgical approach for this particular individual?
What I would like to add here is that, as I said earlier, since it's a very small gland on the ultrasound and a very small gland detected on MIBI, with the biochemical features in mind and all the other symptoms in mind, from the surgical perspective, even though I'm going in localized with the right inferior gland, I am not very happy. I will not be very happy to just explore that gland, even though there is a concordant imaging. So during surgery, I will, if the patient has opted for surgery with me, I will plan for a bilateral exploration, tell the patient that there may be a chance that we look at the other side. And during surgery, we look at the intraoperative PTH fall. If after the excision of this adenoma, the PTH doesn't fall, and to start with, it will be a unilateral exploration, that's for sure. I will also explore on the right, on the same side, the superior gland also. Both the glands will be looked, and the one which is enlarged will be removed. And if the intraoperative PTH doesn't fall, then certainly the other side will be explored, and keeping in mind that the small glands can be a part of hyperplasia.
Adding to what Pradeep said, along with the 4-gland exploration, if all the 4 glands are involved, we would like to explore the carotid sheath also, as well as do a transcervical thymectomy also in this type of setting, having to rule out a MEN1 in case if we get a post-operative, we get a MEN1 to rule out this thymic involvement also. Moreover, IOPTH, I'm little bit personally, I'm not very convinced in case of multiglandular disease, because it works more in case of a uniglandular disease, and in multiglandular disease, I'm a little bit skeptical with the IOPTH, the fall in these cases.
The patient, we went ahead with cervical exploration. The right inferior was found to be enlarged at 1.1 into 0.8 into 0.4 centimeters and was removed. The left inferior was also enlarged at 1.1 into 0.8 into 0.2 centimeters and was removed. The right superior was enlarged, slightly enlarged at 0.8 into 0.4 into 0.3 centimeters and was removed. A normal right superior was visualized. So the patient underwent a 3-gland parathyroidectomy, and like sir said, he underwent a cervical thymectomy. IOPTH fell from 120 to 20 picogram per ml after the 3rd gland was removed, 15 minutes post-excision. Biopsy showed evidence of parathyroid hyperplasia. The right inferior weighed 220 milligrams. The left inferior was enlarged and weighed 120 milligrams. And the right superior was enlarged at 116 milligrams. The thymus was found to be normal. So this was a case of parathyroid hyperplasia. His calcium and PTH came down after surgery, and his calcium levels remain normal at about 6 months of follow-up. Any comments from our chairpersons here, sir?
Any family history or any?
His sister had renal stones, but her calcium was normal, sir.
Okay, okay.
Then, madam.
So, no, so then on examination findings, a lot of men-1 patients will have skin-related manifestations. So it's typical angiofibromas and the adenoma sebaceum, I think. That's right?
Yes.
So we, or lipomas, they can have lipomas, multiple subcutaneous lipomas. So a physical examination, detailed physical examination needs to be looked at if you're not finding any direct clues for men-1 syndrome as such. We look for, definitely, I'm sure you look for prolactin and all that.
Yes, it was normal.
Must be normal.
Yes.
Yeah, fine.
I thank our chairpersons for their valuable insights. We'll now proceed to the next session.
Thanks, everyone. Due to lack of time, we are not presenting the last case. So now we move on to the 3rd session. And I request the chairpersons, Dr. Amit Agarwal, sir. He is the professor and head of Department of Endocrine Surgery from SGPGI Lucknow. Dr. Manisha Sahi, ma'am, she is head of the Department of Nephrology from Osmania Medical College. And Dr. Meher Prasad, he is a senior consultant endocrinologist from Idea Clinics in Chennai. And can I ask Dr. Amit sir, can you please introduce our speaker, Dr. Sanjay Badada sir?
Thank you, Siddharth. A very good morning. It's a pleasure to be the chairperson for this session, and I was enjoying the previous session, which is very interesting. So Sanjay is a dear friend of mine and is a professor of endocrinology at PGI Chandigarh. He's what you call the parathyroid man. So if you go through literature, you will find every aspect of parathyroid has been published by Sanjay, a very prolific writer and a great clinician. So I look forward to his talk in this meeting. Sanjay, you're on.
Hello. Mute तो नहीं है?
Unmute.
Yes, Sanjay, you can share yours. Yeah.
Yeah. Can you see my screen?
I can see. Yeah, we can see your screen here.
And I'm audible to you? Yeah. Okay.
Yes, of course.
Okay. So at the outset, I would like to thank Dr. Rakesh. I am my close friend, and we were together in Banaras Hindu University for 3 years. Dr. Siddharth, the organizing team for this opportunity, and thank you very much, Dr. Amit, for this too good introduction, I think. So anyway, what I'm going to do is next 15 or 20 minutes, I am to take you through the title Lesson Learned from the Indian PHPT Registry. So before starting, I would like to acknowledge my team from PGI. Those are working in PHPT working group. So Dr. Sood, you have already heard him, has delivered very lucid talk. And these two our parathyroid surgeons are there. Parathyroid surgeon Dr. Arunanshu Behra and Dr. Divya Daya, our orthopedic surgeons, and our parathyroid pathologist, and then my PhD scholars, because I am going to present some of their work, though time is less, so not going to much detail of the molecular work, but mainly with relation to the clinical work only. So the PHPT is clinically characterized with pentado PHPT. And
Sanjay, we cannot see your presentation. So you have to click. You can just see the folders.
Pardon? Can't see your...
No. You have to click on your file. You can just see the folders.
Just a minute. Stop share and just share again.
If you open your file and minimize it, and then when you share, it's easy to.
Yeah, just a minute. Now?
Yes. No. Yeah, great. Go ahead.
So I think, could you see this slide?
Yes. Yeah,
okay.
The first slide, yeah.
Thank you. So the primary hyperparathyroidism is classically characterized pentado PHPT, though now the pentado PHPT does not exist in the Western world actually, but still it is true in India. So what we see PHPT in 1940 of Western world is 2020 in India actually. And it is easy to diagnose primary hyperparathyroidism because of classically there is very few causes of high PTH with high calcium level. So that is very few causes are there. So it is easy to diagnose or make a biochemical diagnosis, but then problems start subsequently for the localization. And indeed, I learned a lot from the surgeons in this meeting that how they are facing the problem in the even after localization to take out the tissue. So coming to the brief about the discovery of the parathyroid glands from the Indian connection. So this is a Indian rhinoceros, was a British museum actually. And this rhino actually developed the fracture. So it is very unusual to a rhino develop a fracture. And for that, he was subjected for the autopsy. And they found that 4 tomato-like size glands were there in the neck. And that is parallel to the thyroid gland. Then, so how its name came is the parathyroid glands. Now coming to the prevalence of hypercalcemia in India, because the say calcium is the initial screening test for the primary hyperparathyroidism. So one of our community study that is labeled with the name of Chandigarh Urban Bone Epidemiological Study. So we found only one patient with high calcium, high PTH when we screened around 1,500 community dwelling healthy Indian adults. So primary hyperparathyroidism prevalence is various series, various studies, though unfortunately there is no study from India. And the prevalence is varying from 0.1 to 0.01%. But in India, it is much less, it seems. Or we are missing, we may have to screen more number of patients. Then, but in hospitalized study from our center in 2016 to 2017, 150 patients with sustained hypercalcemia were screened and found the primary hyperparathyroidism major contributor in the 32% of the patients. So primary hyperparathyroidism 80 years ago, what was there is from the historically Captain Charles Martel on the left side. He was a 6 feet height fellow, the Marine commando or the Marine Navy officer in the US Navy. So he was diagnosed with renal stone disease and high calcium, high PTH. And unfortunately, his gland was not localized and he was reduced to significant height from the almost 6 feet 4 inches out to height to the 5 feet 4 inch height. So it reduced to approximately 1 feet height because of this primary hyperparathyroidism. And subsequently, gland was localized in the mediastinum. He was operated upon, but he succumbed to his illness because of the sepsis and because of the multiple fractures. So what is the PHPT? We call PHPT a systemic disease because It can reach to any department wherever you are working. It can reach to urologist because of this renal stone disease. It can reach to orthopedic surgeon very well because of the multiple fractures. Gastroenterologist with the history of pancreatitis, acid peptic disease, of course, nephrologist, renal stone disease, CKD, hematologist with anemia. And we have a very nice publication with relation to the primary hyperpara presenting as with the features of the anemia. They can reach to dental department with the epulis. They can reach to rheumatology department with the joint pains and all these things. They can reach to the pediatrics, or the pediatric surgeons for the presentation in that age group. They can present with even the rickets osteomalacia also. And among all these departments, unfortunately, endocrinologists are dealing most of the primary hyperpara, or the endocrine surgeons are dealing, but directly patients are not reaching to this department because patient doesn't know what is the primary hyperpara and what endocrinologist deals with that. And that's why there is a lot of time gap is there. So it is a time to increase awareness among the general public that primary hyperpara is a disease that exists and that is common and can present to any department, and there should be adequate referral or patient can directly contact the endocrinologist. So when I started working in the PGI, I thought this hyperpara was seen by everyone. It is taking a lot of time. So I thought, let's have a registry, and that we gave a name of Indian PHPT registry. So this Indian PHPT registry was established somewhere in 2010 or 11. It is an online registry, and now around approximately 11 centers of the country are participating. Few of them are already here, and I know Tushar was also supposed to participate. We are in the process to take the ethical clearance for the this one. Dr. Rakesh is already there. Dr. Ganpati, Dr. Manoj Chadda, Dr. Shailesh Lodha, Dr. Masudi from SKIMS, Dr. Parjeet and Dr. Amrish Mittal team, Dr. Rajesh Khadwal from All India Institute, Dr. Dipti from Guwahati, and Dr. Satyanath from IPGMR Kolkata. So many people or the many centers are actually adding their data to the online registry, that is Indian PHPT registry. So this registry, we analyzed the data of 2005 to 2015, and across the 5 centers of the country. Now the more centers are there, and we have around 1,000 patients in this registry. When we analyzed the data, it was around 500 patients were there. So what we found is that obviously this PGI we started long back collecting the data. So more number of patients were represented from our institute. And when we analyzed looking at their symptomatic or asymptomatic presentation, so you can see from 2005 to 2015, the asymptomatic presentation is less than maybe, say, less than 2%, while majority of the patients were symptomatic, and high prevalence, majority of patients were symptomatic in India still. In spite of that increasing awareness, some places there is screening program is going on for the hypercalcemia. Here just showing the center-specific clinical manifestations from Indian PHPT registry. So you can see this presentation is almost same from the all across the centers from our country. Bone pain, the blue bar is tall among all the centers, followed by the fractures. And then you can see that say anemia is also one of the common presentation in most of the centers. So always suspect anemia can be a presenting manifestation of the primary hyperparathyroidism, in addition to the pancreatitis, renal stone disease, and gallstone disease. When we looked at the age of presentation, so you can see across the country, the age of presentation is between the 4th to 5th decade, which is quite different from the Western population, where this disease is called as a disease of the post-menopausal women, while in India, the disease is actually around 40 years of age, it presents with that. Male to female ratio is variable, various centers varying from 2.5 to 2.5 to 1 ratio between female to male. And while in Western country, the ratio is more in favor of the female as compared to the males. Then looked at the various symptoms. I think I already shown you that, but they are comparable most of the centers. Then spectrum of bone disease. So you can see bone loss significantly, fractures, multiple OFCs, then rugged jersey spine, then classical salt and pepper appearance, fractures, nailing, all these things. This is spectrum of bone disease from bone pain to fractures to bed-bound condition. Then you can see the spectrum of stone disease. The pancreatic calcification, though it is less frequent as compared to the renal stone disease, unilateral, bilateral, nephrocalcinosis, large stones, small stones, urinary calculi, urinary bladder calculi, and also. So there is spectrum of stone disease also there, and that's why it is still correct that the hyperpara in India is bone and stone disease. Looking at the biochemical parameters, hypercalcemia is universal on all the centers. The maximum calcium level found from the Fortis Hospital, Jaipur center, and that may be because of the Jaipur is a place where this climate is more hot and maybe partly contributed by the dehydration that may be a cause for the more significant hypercalcemia as compared to other centers. And the creatinine level was comparable across the centers. Alkaline phosphatase level is directly correlated with the vitamin D. The centers with the vitamin D level was low. Alkaline phosphatase was very high. And I think the centers like All India Institute with the vitamin D of that group of patients was around 12 nanogram per ml. And that's why the alkaline phosphatase was very high. But nevertheless, from each center, the ALP level is very, very high. So it is also an indicator. If you see a patient or the report of elevated alkaline phosphatase, you must think about the primary hyperpara also in addition to the vitamin D deficiency. Now I'll take you an interesting patient that is a diagnostic dilemma and a problem. A 30-year-old male patient presented with to our gastroenterology services. And you know that the CT scan, that is classical pseudopancreatic cyst is there. Though the patient also had a renal stone disease, but the patient was not symptomatic for that. When patient was investigated, found to have the renal stones here. Looked at the calcium. So calcium was high, phosphate was low normal, alkaline phosphatase was also borderlinely elevated, but PTH was 3 and 1. So it was a disturbing that the patient is having pancreatitis and renal stone disease, so very much favoring the primary hyperpara, but the problem was that PTH was low. So we ruled out all other causes of pancreatitis, and but there was PTH was low. And then we subjected the patient for the system AB scan, and you can see very nice uptake is there on the system AB scan. And so we were sure that because system AB scan is in our previous publication is sensitivity and specificity of more than 90% to localize the parathyroid gland. So this patient was subjected for the surgery, and post-operatively his PTH was improved, normalized from the suppressed PTH. And so basically sometimes you can see a patient of very low or undetectable intact parathyroid hormone level with surgically verified parathyroid adenoma. So it happened because the parathyroid hormone which was secreted from the gland, which was actually biologically active but non-immunoreactive with the available assay analysis. So that sometimes can cause a problem. So, and from this particular slide, what I'm trying to show is that we compare 3 types of pancreatitis. These chronic pancreatitis because of PHPT, because of alcohol, and because of the idiopathy. And this interesting observation from this study was that if a patient of pancreatitis is having the renal stone disease, it is almost certain that you are dealing with the primary hyperpara. So the audience, it is an important information. If the patient is having the renal stone disease with pancreatitis, always think about the primary hyperpara. And interestingly, all these patients when operated, none of the patients had recurrence of pancreatitis. So that is very gratifying. Otherwise, the patients of PHP with pancreatitis are keep coming to the hospital with the recurrent pancreatitis. Now, looking when we analyzed our data from 1995 to 2019 over a period of approximately 25 years. So in initial years, there was hardly any asymptomatic PHPT, but now we can see the progressively rise in the asymptomatic PHPT. So we compare the young and old patients with adult patients with the primary hyperpara. There was no significant difference between these two groups. And continent specific presentation we already alluded and said that there is a PHPT in India is same, but in various other continent is different, like very severe in the India or the Asian countries, maybe moderately severe in the Latin America and European countries, and the much milder in the US. And the age is again increasing with the decreasing the severity. So PHPT in India, from the Indian PHPT registry and the data collected from the 5 centers and other centers, we can say presentation of PHPT in India at younger age. Almost all are symptomatic. Mortality, majority are vitamin D deficient. Still, the vitamin D is prescribed a lot and higher adenoma weight as compared to the Western population. So pathogens of PHPT is candidates involved are various genes are involved, BDR, CSR. But I think this gathering here may not require this further details on the mutation analysis or the genetics or the epigenetics. So I'll end my presentation here. And I would like to thank my department colleagues and faculty and residents, PhD scholars for their help and to support this. Thank you very much. I'll be happy to take if any question or comments are there.
Thank you, Sanjay, for a very lucid talk and a very conclusive, summary of the lessons which you learned from the registry, Parathyroid Registry of India, and how it compares with the Western literature. So if there are any questions, I'm sure Sanjay would be happy to respond to.
Yes, sir.
So I'll just make a brief comment. We analyzed our own data of pancreatitis and found that the prevalence was around 8.5%. So we have around 45 cases of pancreatitis, and they're very young, young adults. And interestingly, none of them had any attack after the parathyroid was removed. So it's a very, very gratifying surgery. And these children had 5 or 6 attacks of pancreatitis, and we also had to do a semi-emergent parathyroidectomy. So the takeaway is that the surgeon should not deter from doing a parathyroidectomy even if the amylase and lipase are high, because it's curative for these.
Yes. So that is really very, very good information, because otherwise the pancreatitis patients are keep coming to the hospital every 3 months, 6 months.
Yeah.
And they are keep missing. The other misleading thing is that calcium may not be sometime very high because of the saponification. So calcium may be on the little lower side as compared to the classical hyperpara where the pH calcium is really high.
Yeah. In fact, I teach my residents, if you get a normal calcium with pancreatitis, suspect PHPT.
Yes. Exactly.
Normally calcium should be low with
our Bailey teaching saponification causes in pancreatitis and reduces the calcium level actually.
Yeah. But I enjoyed the spectrum of the, stone disease and the bone disease. So can I ask you, what do you think is the reason that we still see such severe hyperpara in this part of the world?
Yeah. So, Dr. Amit, actually, indeed, now trend is changing. What I believe is one thing is correct, that there is almost a decade earlier onset of disease is there, and that we cannot deny, because you take diabetes. The Western population mean age of diabetes is 45 years. In India, mean age of diabetes is 35 years. You take osteoporosis. Mean age of osteoporosis in Western population is 65 years. Here we see in a 55 years. So we are having a 1 decade earlier onset of majority of the disease. So that is always there. In addition to that, maybe vitamin D deficiency is still rampant in our country. That may be further contributing it. And the third and most important thing is that the calcium estimation, which is done by the in the routine laboratory at the periphery, is not by auto-analyzer. And indeed, that auto-analyzer has a range very wide. Say 11 is the upper range, while in any auto-analyzer, the upper range is 10.2 or 10.5. So obviously, a physician will see the report that, okay, this is calcium is in the normal range. So he'll don't bother that. He will, even if he's knowing that it can be hyperpara, but he will think, no, calcium is normal. And he will leave it like that. So probably we have to think from this side. And what we do is that any patient comes with a calcium outside 10.5, 11. What we do, we ask him to repeat from the institute or from the auto-analyzer. And invariably, patient is having renal stone disease, their calcium is high, and when we repeat in our institute. So that is another message I want to give to our colleagues, friends, that you should always get a calcium profile also very appropriately. In addition to that, problem we know with the PTH also, because it's not collected properly. That will be heat labile and value will come erroneously low only.
So just in continuation, would you recommend ionized calcium? It's very important that...
So I think ionized calcium can be done, but the other issue is the ionized calcium, most of the places is done with the arterial blood gases only. Not frequently ionized calcium is not done actually. So what I suggest that best is to do by the auto analyzer. That will be very, very helpful rather than, but yes, you can do ionized calcium also. That is a good suggestion when you are feeling that you are suspecting strongly clinically hyperpara, but calcium is low, then definitely we can ask for that ionized calcium.
Yeah, the reason I said because a lot of our patients are actually calcium deficient. The calcium intake is very poor, and that complicates the PTH hyperpara picture in our patients.
Yeah, exactly, Dr. Amit. You brought very good point into the discussion that not only the vitamin D, but calcium is also playing an equal role, and that's why the low calcium diet as well as low vitamin D probably making the disease much more worse in our scenario as compared to the Western population. And young kids are presenting with rickets, frank rickets. They are presenting with the frank rickets. When we are treating with that vitamin D, they are presenting with the hypercalcemia, and that is very well known fact. So that we should keep in mind. I think in this gathering that lot of pediatric surgeons are there. That may be of importance for them also, that we should suspect the rickets can be a presenting manifestation of primary hyperpara. Of course, that is unusual, but it is can be an important reason, and patient can present with the pancreatitis because of this reason. You supplement adequate vitamin D, calcium start rising, and then if you're not following, they will present with the pancreatitis again.
Dr. Badada, if I can just make a small point. What
yes,
ma'am. Our message to the nephrologist? First of all, excellent lecture. Nephro or urologist, what would be the message? For example, with a normal calcium done properly, if it's in the normal range, phosphorus is normal. Your message to them if comes with recurrent stones, because there are other causes also like idiopathic hypercalciuria, RTAs, which we see along with primary hyperpara. So what would be your one message?
So, ma'am, thank you, Dr. Manisha, and for asking the great question. So actually, if you look at the renal stone disease, the etiology of renal stone disease, hyperpara will be the top cause. And there is 3 important predictors of primary hyperpara or the metabolic cause of the renal stone disease, because we know that idiopathic renal stone disease is also common. But if patient is having bilateral renal stone disease, patient is having renal stone disease with nephrocalcinosis, if patient is having calcification other than renal stone disease elsewhere, then there is a very high chances that we are dealing with a patient of primary hyperpara. So we did one study with our urology department, and where we did what we did is all renal stone disease patients were screened for the primary hyperpara. So we found approximately 5 to 8% of patients of renal stone disease, actually the cause was the primary hyperpara, and successfully operated on these patients. So what I recommend is all patients with renal stone disease should be screened for the PTH and the calcium profile.
Despite calcium and phosphorus, everything being normal from a standard lab, would you still say that? Because idiopathic, we are taught that idiopathic hypercalciuria is the first common cause. Again, you have bilateral stone disease, nephrocalcinosis. Then this RTA is the second important cause, and third important is primary hyperpara. So do this, like if calcium.
I suggest you reverse the order. Primary hyperpara is topper one, and yes, RTA, I agree with you. But you see, in RTA, you have hypokalemia, you have the rickets changes, so many other pointers are there by which you can easily differentiate that you are dealing with primary hyperpara, you are dealing with the RTA actually.
So you recommend PTH for all, despite calcium and phosphorus being normal. Is that the message?
So if vitamin D is normal, you can get vitamin D also. If the vitamin D is normal and PTH is high, definitely you should suspect the primary hyperpara, definitely, yeah. Or you just supplement with vitamin D if deficiency, and still look for the PTH. If it is high, then there are very high chances of primary hyperpara. And remember, it is very gratifying to treat primary hyperpara, because for physician, it is easy to diagnose, localize, send to Dr. Amit and all surgeons. Let them struggle and let them operate, give the data without complication, follow up and all these things. But multiple endocrine neoplasia is one of the thing, and we are seeing lot of patients of multiple endocrine neoplasia. And now people are started telling primary hyperpara is a genetic disease, not a sporadic disease. So maybe whenever we'll meet next time, I'll show you the data that how primary hyperpara is not a sporadic disease, it is a genetic disease because of the multiple genes are involved here.
Series, excellent series. How many patients had CKD and still had primary hyperpara? I mean, did you have those patients as well?
The CKD hyperpara, and we have separate number of patients, and we are using the localization and operating these patients for the parathyroidectomy. If the PTH level is more than 1000 picogram per ml, and in spite of good treatment with the sinacalcet, if the PTH is not lowering, we are subjecting these patients for the surgery. And it is known that these patients, when they are undergoing the renal transplant, they may be fare better if their PTH is good and they are operated prior to that.
Sorry to interrupt, sir. Wonderful session, but due to short of time, we have to go to the thanks a lot. Dr. Amit sir, there's a small change. Can you introduce Dr. Deepak Abraham will be presenting the next session, and after that, Dr. Shyam.
Yeah, so thank you, Sanjay. So next speaker is Dr. Deepak, who's a great friend of mine, and he's my contemporary from CMC Vellore. He has done great work in endocrine surgery, particularly medullary thyroid cancers and hyperparathyroid. So, and he's one of the most sought after speakers in the country, both in the endocrine circles as well as in the head and neck conferences. So I'll invite Dr. Deepak to give his talk. So he'll be speaking on.
Thanks, Amit.
Go ahead. Yeah.
Thanks, Amit. Thank you for that invitation, the introduction, and to Siddharth and to Rakesh for this platform to share our experience. It's always a pleasure to speak on parathyroid disease. I just like to comment on what Dr. Sanjay ended saying, surgeons struggle, but once surgeons have mapped out the whole thing, it's a very gratifying operation too for surgeons to operate on patients with hyperparathyroidism. With that, I'll start. I think the title said about use of SVS. SVS is very, let me say, very niche investigation to use. I'm speaking on adjuncts, and is my screen visible? Audio,
yes, Deepak. Yes, audio is fine. Yes.
Yeah. Okay, great. So I'm speaking on the role of intraoperative adjuncts, and so primarily it would be frozen section, intraoperative PTH, and I'll also speak on SVS. And I must say that our experience with SVS is pretty much just 2 cases. But that itself, I know, is quite an experience for us. The first thing I'd like to share about is my outline is we're going to start with case presentations, and then I'd speak on adjuncts and SVS, and finally speak on what is our own CMC's experience. So, and I'm speaking on 2 of our failures, 2 patients who we operated. This one was just a couple of months ago. A young 49-year-old lady from North India who had come to us with renal stones referred to us by the urologist. Again, had proximal myopathy, dyspepsia, all the features which were shown in the previous talk on about symptomatic PHPT. And there was no mass in the neck. On examination, there was PTH. It's clear-cut PHPT. PTH was 147. I corrected calcium was 11. So we went ahead and we localized it along with the staging, in terms of end organ damage assessment, which is the bone mineral density and kidney stone. And we had seen what was reported as a left inferior parathyroid. And you can see that in the SESTIM-EB and in the SPECT, as well as in the ultrasound. So, and I'd like to bring one point which possibly has not been spoken about is the role of using an oblique image in the planar MEB and using a pinhole, which was done when I was a junior consultant, maybe in early 2000, 2003, 4. And they always did an oblique image prior to using SPECT. And that would tell us about whether the lesion was more posteriorly located versus more anteriorly located, and hence differentiate between an inferior parathyroid adenoma versus a descended superior parathyroid adenoma. And this case is a classic example of such a patient. So this patient underwent a focused left inferior parathyroidectomy. And was, slightly, they identified the parathyroid correctly. It was 150 milligrams by weight. And what was inspected, the unilateral on the same ipsilateral side as left superior parathyroid normal. But unfortunately, this patient was not cured. We had not used adjuncts at that point. We just said it's 150 milligrams. We think we should cure the patient, and we went ahead and closed. And the biopsy came back as normal parathyroid tissue with no abnormality. So I had to do a bit of convincing to this patient to say, listen, we'll cure you. It's just that we have missed out. So we went on ahead and added on a 4D CT scan to this patient. And this patient was actually presented by Ritu this morning when she presented her role of 4D CT. And you can see that this is a very posteriorly located, almost just close to the vertebra. And that was a descended superior. So we went ahead and operated again. And very clearly, we also used 2 adjuncts to make sure that we're sure. We had an IOPTH and a frozen biopsy. The IOPTH, so we modify our criteria. We don't use the exact all values. We use 1 pre-incision and a 20-minute post-excision, and also used a frozen section. But we were very clear we got the biopsy. The moment the tumor was out, we got the report. It was 550 milligrams in terms of weight, and we knew that we've cured the patient. And sure enough, she was cured. Post-op PTH was 17. This is a second patient, which was another of our failures. So you must be wondering why I'm speaking of my failures. But I think if you're confident to speak about failures, you're pretty much doing a good job, and then you're willing to speak about your failures. And this was a BSF soldier from the border. He was 36-year-old, came again with renal stones, came again to urology department, worked up, found to be hypercalcemic, came to us again very clear-cut in terms of the diagnosis, in terms of biochemistry. So we went ahead and we did localizing, and was considered to have a left inferior parathyroid adenoma. But at that, this was done a decade ago, and this patient at that point of time, this was posted as the last patient, and I remember this was beyond 5 o'clock, and we couldn't send a frozen. And what happened was we we actually didn't identify clear-cut an adenoma. We thought about possibly an intrathyroidal parathyroid adenoma, and we did a left hemithyroidectomy. And the biopsy came back as normal thyroid tissue. So post-operative period again did not cure. PTH was 170, calcium was 11.5, and we went ahead. This patient had to go back actually to report to duty. And I convinced him to come back in 3 months to say, listen, we will definitely sort you out. Please come again. We'll make sure that we'll cure you. And so that time, this was one of the first 4D CTs we did. This was like in maybe 2011 or 12. And when we started using 4D CT scan, and this was a lesion which was seen to be along the brachiocephalic vein. Yeah, and then we also did a selective venous sampling in this patient. And the key is to actually take sample both from the peripheral vein and from the location in which the catheter is, so that you have 2 values to compare because of the short half-life of PTH. And we went ahead and did this. This was mapped out values of the PTH from the various locations, and knew that this was in the right paratracheal region, just above the brachiocephalic vein, and it's possibly in the thymus. So we went ahead and did an exploration. It was, I remember doing this operation extremely difficult because it was a redo. So I did a lateral approach, went in from lateral to the sternocleidomastoid, cut the strap muscles, and went directly into the thymus and pulled out the adenoma from the mediastinum. And that was also a 570 milligram tumor, and was cured. And this patient was also cured. That brings me to what my topic is, and use of intraoperative adjuncts, and is to the use of intraoperative PTH, as Dalapati, I think, mentioned, it's not very useful in patients who have multiglandular disease, but definitely in single adenomas or even maybe a double adenoma, you will get a cure and you will get evidence on your IOPTH. I must say that we do not have an IOPTH in our theater, but we trigger the whole system in place, including biochemistry, to say, we are sending you 5 tubes or 4 tubes or whatever, and say, please run them together and give us a value. So we are able to get the value in about 30 to 40 minutes. So we do a pre-incision, pre-excision, post-excision 5 minutes, and a post-excision 10 minutes. And Miami criteria say a drop in 50% of more from the pre-incision or the pre-excision value. And Vienna says drop in 50% or more from the pre-incision value. A combination of these two have their highest accuracy. So as I showed you in the previous patient, that we do that in a sort of a modified version, taking either the 10-minute or a 20-minute value, and then send only 2 values. But the advantage of an IOPTH is you have proof that you have cured the patient at the end of the operation by objective evidence to say, yes, these are the values and we know that we cured you. You don't have to wait for your next day PTH to make that decision. So the next is the role of frozen section. Very useful. This was a tool we used for every patient with PHPT prior to good imaging. So I remember when I was a postgraduate registrar, every patient with a PHPT operated was a 4-gland exploration plus a frozen section. You send the frozen biopsy to confirm whether, you send the sample for a frozen to get a confirmation that it was PHPT. So what they would say is, you've got hypercellular parathyroid tissue. They cannot tell you parathyroid adenoma versus hyperplasia. But if you send them 2 glands, like one which is an adenomatous and a normal, or a half of a normal, you will find that this patient has got a proof to say that they have that this patient has got a adenoma, because they've got normal parathyroid and hypercellular parathyroid tissue. Now coming to our own frozen, but yes, as I said, you need to have an experienced endocrine pathologist, and we are very fortunate to have an endocrine pathology team who can take care of these things, along with an endocrine radiology team, which supports us with all this imaging, and Ritu is a big help to us, especially in dealing with complicated cases. And our departmental data, and I must say that this was till 2020. This was from the year we started doing focused parathyroidectomies. We have a total of 625 cases whose data is complete. Age was mean age was about 45.1 years, and the youngest was 14. And as normally seen, it's a more female preponderance. And you can see that the clinical presentation is pretty much what was shown in the previous. It's primarily stones and bones, which are the main symptoms, and asymptomatic is still a low a low number. And over the years, I was thinking that the asymptomatics would go up, but that's not true. It's not happening. It's still the symptomatics which are coming to us. And we have, in the 625 patients was up to 2020. We had a dip in the year when we had the COVID. Following that, in 2021, we had another 68 cases which have not been added into this analysis. And the mean pre-op calcium was about 12.2. So, it's quite significant disease. And our primary modality of workup is always ultrasound and a MEB, and add on 4D CT only if required. So, and a common approach, or the most significant approach, is to go via using the focused parathyroidectomy. And in those patients who require a bilateral neck exploration, we would do that, especially when there's coexistent thyroid disease. We have also experience using doing parathyroidectomy under local anesthesia, but that is primarily from a pressure of lack of operating time. And I said, see, 625 patients, ultrasound and MEB were then, and 583 of them. And even in discordant imaging, we were able to do a subset of them to a focused approach. And our bilateral NAC exploration, the most common reason was of coexistent pathology in the thyroid disease, or it was a surgeon's choice to say, and our boss, our mentor, we used to do 4 gland for every patient. For some reason, the slide's doing an auto move. Anyway, most of the patients were adenomas, with a few of our patients with carcinoma, 11 patients. And this is how we would do a focused parathyroidectomy. This is done under local anesthesia, and you can see it just pops out when you target your incision. And the mean gland weight is about 2.5 grams. We've had 14 failed explorations. 13 of them were re-explored, 12 were cured, 1 was not cured. And that was one patient who actually had an SVS2. And he had the localization to the right side of the neck, but for some reason could not be cured, and has not come back to us. We have one patient on follow-up with a mediastinal adenoma, but there's not one surgery. And so we had a 99% overall cure rate and a 97% cure rate after the first operation. So an increase in 2% when we go back into the neck. But the key is to get the confidence of the patient to trust you to go back into the neck the second time. Though I must say the best operation is the first operation. So in conclusion, I think did I miss a slide? Yeah. This is about morbidities. Hypocalcemia is a problem. Voice change 2% is our data, even from our thyroid audit, that we have about a 2% recurrent laryngeal nerve palsy, most of them temporary, but yes, and failed exploration was about 14 patients in the 625. And so we need a good parathyroid surgeon, you need good endocrinologist, you need a good sonologist, you need a good nuclear physician, and above all, you need good communication. Thank you, and I'm happy to take any questions.
Thank you, Deepak. As always, a very lucid talk, and you summarized your data about that gives confidence to most of the young parathyroid surgeons that it's a very gratifying operation. But you need to have a good sonologist and a nuclear physician and an endocrinologist. So unless you have that good parathyroid team, as I call it, the results will not be as good as in your case of more than 99%. And of course, it's good to have, good to resort to new technologies, use of intraoperative PTH. See, parathyroid surgery is easy for the localized. It's the unlocalized or the multiglandular disease that creates some issues for the parathyroid surgeon. So, any tips for the young surgeons about dealing with the multiglandular disease?
Yeah, I mean, I think in multiglandular disease, having a good anatomical understanding of the neck and identifying where parathyroids can be hidden, in the carotid sheath, retroesophageal, paraesophageal, retrotracheal, even like what was shown by Ritu, where it was sitting high up in the carotid sheath in a 16-year-old girl. And we missed out on the first time and then went back in and found when we restudied the primary imaging, it was a salivary gland uptake was very bright in the MEB. And so identifying, going into the neck after good thorough workup or a thorough preoperative workup, followed by a good intraoperative understanding of the anatomy of the neck and understanding that the inferiors can be more widely located. Superiors are more confined to that region where the inferior thyroid artery crosses the recurrent laryngeal nerve, 2 centimeters, you draw a circle, you'll get the parathyroid. But apart from that, the ectopics, and also to remember that there's an option of that being an intrathyroidal parathyroid. So identifying these is very important, and that will help you the other point which I'd like to make, Amit, is open the capsule of the thyroid. It's in opening the capsule when I teach residents, I do a snip and a strip. So I've changed from snip and a strip to snip and a slide it down. You slide down the fascia, you'll actually see the parathyroids better. And so that is another thing to keep in mind. So looking for the parathyroids. Yeah.
Very good tips. Yeah, there's one important provocative question. So if you have a biochemically confirmed hyperparathyroidism, which is non-localized, would you proceed to a bilateral exploration, or would you go to 4D-CT and a choline or a methionine PET scan?
Okay, I'll just tell you one. I'm actually operating one on Monday. So she's a lady who's been diagnosed clear-cut hyperpara. So we did system EB and ultrasound, did not localize. We actually went and did a 4D-CT. And the 4D-CT was also not clear. Unfortunately, I don't have a choline PET or a PET because with that, we don't have an option to do it in Vellore. You have to send them either to Bangalore. So we decided to go ahead and operate tomorrow. Tomorrow, doing a 4-gland. So yes, I'm doing a 4-gland tomorrow, but we are using ultrasound, maybe if both have not got it, go for a 4D-CT prior to going for surgery.
Yes, great. Any other questions from the delegates, audience, or the faculty?
Dr. Deepak, very nice talk. So do you do at least 2 imaging modalities before going for surgery, or you rely on single one?
No, two definitely. Two definitely for concordance. Add on the third if discordant or one of them don't show it.
Right. Actually, we are also following the same pattern there. And do you have any different for the CKD or tertiary hyperpara with severe secondary hyperpara patient undergoing for the renal transplant?
So when that comes to us, we often have, we plan a 4-gland exploration for those patients. And in that situation, very often renal failure may not even allow you to do any of the imaging because of the contrast. So we go ahead and do a 4-gland in that situation. But if you've got tertiary, you may have imaging which helps you go to the gland which is affected.
Right. And are you doing some auto-transplantation?
Auto-transplantation
is your preferred site?
Is the sternocleidomastoid. Okay. So the only time we have done hypo in the brachyradialis for our neonatal hyperparas. It's easy to go back. It's easy to go back into the hand for the small child.
Thank you, Deepak. Over to Dr. Siddharth for the
thanks. Thank you so much.
Thank you, sir. Now I call upon Dr. Meher sir to introduce Dr. Shyam Kalavalpalli for the next talk. Dr. Meher. Sir, you have to unmute yourself. Dr. Meher, you are muted. Yes, sir.
You see me? Yeah.
Yes, sir.
Hi. It's been an excellent presentation till now, and I have a great pleasure in introducing my friend Shyam Kalavalpalli. We've been through our education together. So he welcome Shyam, and hand over the podium to you. You can start your presentation on hyperparathyroidism and MEN1 syndrome.
Yeah, thank you, Meher. Thank you, Dr. Siddharth and Dr. Rakesh. I think I'm presenting 2 cases which we published a while ago to understand the bit more about MEN1 and hyperpara. So the first case was my precious one, because that was my first oral presentation at British Endocrine Society. This was a 29-year-old woman who was admitted with hematemesis due to peptic ulcer. She was on omeprazole, and she was found to be hypercalcemic. So biochemically, she had primary hyperparathyroidism, and she had single gland parathyroidectomy. Because of this peptic ulcer and high calcium, they suspected gastrinoma as part of MEN1. So the the doctors at that hospital tried to measure fasting gut hormones. To measure gastrin, we have to stop the PPIs. And unfortunately, patient ended up with a GI perforation. So then they referred to us. We were training at Hammersmith at that time. This was almost 20 years ago. So this patient who had hyperparathyroidism, she came to us. She had hypercalcemia. Her corrected calcium was raised. And she had continued to have primary hyperparathyroidism. So the remaining 3 parathyroid glands were resected. And her prolactin was marginally raised. Pituitary MRI confirmed a micro adenoma. So MEN1 was confirmed. Because we decided not to investigate further because the gastrinoma could be medically managed at that time, we thought we would discharge. But on the previous night, she complained of severe lightheadedness and sweating relieved by eating. So this made us think about other possibility, which is insulinoma. So we postponed her discharge. We initiated three-day fast. Within first 8 hours, she became hypoglycemic. And CT scan showed and endoscopic ultrasound both confirmed 2 lesions in the head of pancreas and 1 adenoma in the tail. So this lady ended up having 2 lumps in the head of pancreas and 1 at the tail. So we have octreotide scan at Hammersmith at that time. So the lesions in the head took up octreotide avid, whilst the lesion in the tail did not pick up octreotide. So usually insulinomas are not octreotide avid as opposed to gastrinomas. So this raises suspicion of gastrinoma and insulinoma in a patient with MEN1. So then we thought we should proceed with calcium stimulation test to identify which of these lesions are gastrinomas or insulinomas to confirm. I'm not a surgeon. The anatomy of pancreas. Again, what happens during calcium stimulation test is they catheterize from both femoral artery and from one groin, they catheterize the femoral vein, the other one into femoral artery, and the vein, they get into the hepatic vein. This is to collect the samples. And through the femoral artery, they catheterize different territories of the pancreas, predominantly the pancreatic artery, superior mesenteric artery, splenic artery. These are the major territories. They usually catheterize to inject calcium or secretin, whichever to stimulate the hormones. And through the hepatic vein, they take the sample. So as trainees, we were assigned the task of collecting the sample and all that stuff. So it was a very, high intense event. So on the day, when they did, there were 2 angiographic blushes in the head of pancreas in the territory supplied by the inferior pancreatic artery and superior mesenteric artery. And there was a significant rise in gastrin concentration in these areas. A 3rd blush was seen in the tail of the pancreas where we suspected insulinoma, which is supplied by splenic artery. So there was a marked increase in the insulin secretion in that. So how we did that is we stopped the diazoxide a day before we initiated dextrose infusion. We maintained glucose above, 18 into 3 is above 50. And we were the assistants trying to arrange the whole process. So as I was telling, the catheter was placed in the hepatic vein to collect these samples. And angiography was done into each artery: proximal gastroduodenal, proximal splenic, hepatic, and superior mesenteric artery. So they all start with least likely vessel first. So they don't go to the most likely one. So they inject the dye into the most least likely territory and then move forward. So we take 2 baseline samples as -120 and 0 seconds. We inject the secretin and calcium. Blood samples are taken every 30 seconds. So one of us have to do countdown 10 seconds before each sample is, injected. So the sample those days were stored in ice, quickly rushed to the lab within 15 minutes. Insulin should be separated, and that doesn't need to be stored on ice. So in this, the indication is when we suspect insulinomas and all that, when we cannot confirm the territory of this lesion. So what we expect is twofold rise in insulin levels in the hepatic venous sample at 30 seconds or 60 seconds. There should be doubling of the basal value to the post-stimulant value. So as you can see here, this is the gastrin levels. What we have found is, as you can see with the yellow bar and the light blue bar, superior mesenteric artery and inferior pancreaticoduodenal artery territory, there is doubling at 30 seconds, or 30 to 60 seconds is doubling of the gastrin levels. And the insulin levels, the orange line, which is the splenic artery territory, there is doubling. So both confirmed the lesions we identified on the scan and through angiographic blush. So we could, these are the numbers. As you can see, the inferior pancreaticoduodenal artery territory, it doubled from 1200 to almost 4000. The superior mesenteric artery, the gastrin levels doubled from 1200 to 4000. Insulin levels, at 30, 60 seconds, it went up to more than double. So this confirmed that we are dealing with MEN1 with primary hyperpara, causing 2 gastrinomas in head of pancreas and one insulinoma in the tail. So primary hyperpara, microprolactinoma, 2 pancreatic head gastrinoma, and a pancreatic tail insulinoma. And she underwent surgery, which confirmed on histology. So this case highlighted coexistence of multiple pancreatic tumors in MEN1. And if we miss the history taking and didn't suspect, probably this could have gone for a little longer. The next case is another MEN1, which we published 10 years ago. This was something which, like all of us, we thought it's straightforward primary hyperparathyroidism. After a few years, she presented to us with metastatic lesions in the lung. So basically, this is a patient with MEN1 presenting with primary hyperpara. The actual diagnosis of metastatic parathyroid carcinoma was delayed until the METs were discovered. So this was a 44-year-old lady presented with initially some aches and pains. She found to have biochemical evidence of hyperpara. She had single gland, right lower parathyroid gland resection. The histology just showed cellular parathyroid gland. And it was difficult to differentiate between adenoma and hyperplasia because they didn't look at the other glands. She was, her calcium normalized, she was well, so she was discharged. Unfortunately, she represented after a while with recurrence of hypercalcemia and raised parathyroid. So then raised a suspicion of MEN1. What has happened is she, in the meantime, she had because of MEN1, the other glands were resected. Calcium became normal. And she underwent some other surgery for a hysterectomy for, she developed endometriosis for which she had scans. During CT scan, she was incidentally found to have some lung lesions, which initially didn't reveal much. And then as part of MEN1, her growth hormone levels, IGF-1 levels were raised. She didn't have any clinical acromegaly. She didn't look acromegalic. So we did OGTT, which there is non-suppression of growth hormone after glucose. All this put us in a very difficult situation dealing with lung lesions with primary MEN1 and
conference CDRI.
And basically the lung lesion on histology showed parathyroid.
तो कल सुबह मैं 11 बजे फोन करूंगा आपको, मैं वापस आ जाऊंगा.
Okay. So basically, this patient had lung lesions and also lung histology revealed parathyroid tissue. So the problem with parathyroid carcinoma is histology may not be as reliable. It's usually suspected when there is local invasion of contiguous structures or where there is gross capsular or vascular invasion, or there is a distant metastasis to lymph nodes or other organs. In our case, it was to the lung. So parathyroid carcinoma is a slow growing and metastasis very late. There could be deposits in the lungs in 40% of cases, sometimes to lymph nodes or liver. And the treatment is predominantly surgical resection. And the main problem is with hypercalcemia. The mortality is more hormonally driven due to biochemical disturbance rather than due to tumor invasion per se. So as I was showing this is the lesion. MRI demonstrated a pituitary macroadenoma for which she had surgery. Lung mets were demonstrated. The lung histology showed parathyroid tissue, and the pituitary tissue showed eosinophilic cells in keeping with acromegaly and prolactin levels. So we do gut hormones for all patients. So usually when we request gut hormones, they do, all these, there is a profile of all these 8 hormones which came back normal. The OGTT demonstrated acromegaly. So bottom line is we had this case, but unfortunately she had silent acromegaly. She had silent acromegaly, and she remained. Her calcium was and the management is to ensure that we I think somebody is okay. Anyway, I think we'll stop here. Any questions? Thank you.
Avik, can you mute Dr. Sudhakar Rao?
Any other questions from the board?
Avik, can you mute everyone?
Yeah.
Yeah. Yeah. Thank you, Dr. Shyam. Any questions from the audience? Okay, thank you. So we move on to the next session. We invite Dr. Ravi Mehrotra, sir. Dr. Amit, sir, can you please introduce Dr. Mehrotra, sir?
Yes, sure. So it's a pleasure to introduce Dr. Ravi Mehrotra. We were together in ZPGI almost 20-25 years back. And Ravi is a topmost endocrinologist of the country. He's a thorough gentleman, and it will be a pleasure to listen to Ravi for his talk. So Ravi, you're on.
Dr. Shyam, you'll have to stop sharing the screen.
Is my slide visible and I'm audible?
You are audible, but we can't see your slides yet.
Dr. Shyam, you'll have to stop sharing the screen. Dr. Shyam, you'll have to stop sharing your screen.
Yeah, I'm trying to do that.
There's a red line, red bar on the top which says stop share screen. Red button on top.
Where?
On top. Red button on top. Yeah.
Is the slide screen visible now?
Yes, visible. Can you make it slideshow?
Yeah, it's slideshow now.
No, we are not seeing the slideshow. Maybe you'll have to stop sharing and do it again.
Yes.
It's slideshow now?
Not yet.
I am seeing a slideshow. I'll do it again. Maybe. Now?
Yes.
Yeah. Good afternoon, everybody. And I suppose I'm the last one to speak. Thank you, Idea Clinics and Dr. Siddharth for inviting me today. My topic of discussion today is to look at the renal hyperpara and tertiary hyperpara. Before we go on to really look at the management of renal hyperpara, it's better to understand the pathophysiology of the secondary hyperpara and the renal failure, and that will make our job of management easier. Any comment? Now, when we treat these patients, it's not only treating the looking at the calcium numbers or the phosphorus number. Basically, understand they are a very important predictor of mortality in these patients. If you look at here, the PTH, higher PTH mean more increased risk of death. Look at the calcium level, the higher the calcium, the more risk of death is there. Human phosphorus has got dual relationship. The higher the phosphorus and the lesser the phosphorus, the mortality tends to increase. The calcium and phosphorus product again increases the risk of mortality. So basically, it's not only the calcium and phosphorus metabolic bone disease. You're looking at the mortality in these patients by these disease process. Now, this basically slide is known to everybody in this room, and we know that in a normal person with normal renal function, parathormone basically is responsible for calcium resorption from the tubules and the bone resorption. And in turn, the calcitriol and calcium will regulate the PTH secretion, and the higher the phosphorus will stimulate the PTH secretion. FGF relationship with the PTH is a little bit controversial. It's being looked at into it. FGF will basically act with the FGF receptor and the clotho receptor together will act together to have the impact on the PTH metabolism. When the GFR starts to decline, typically when the GFR starts to go less than 30 to 40, the urinary phosphorus clearance will decline, leading to more phosphorus, which will stimulate the SGF23, which will in turn inhibit the 1-alpha hydroxylase enzyme, which will leading to decreased synthesis of 125 vitamin D, leading to decreased calcium, and high phosphorus and decreased calcium will lead to increased parathyroid secretion. Now, it's not only the simple secretion of PTH which increases. Now, as the disease will progress, there's a loss of vitamin D and the calcium receptor in the PTH cells. The expression is less, and that will further basically make the PTH cell more independent. The PTH will, the secretion is more, and the proliferation is more. And again, the relationship of FGF23, the FGF receptors are going down, but the exact relationship is not well known as of now. It's under evaluation. We can look at here, as still the secretions are more and the cell number are multiplying more, it is polyclonal in origin. The disease is basically polyclonal, but somewhere down the line, the disease becomes monoclonal. And it is said these loss of vitamin D receptor and the calcium receptor could be a early abnormality in the cell, which can cause the disease process to become monoclonal. But again, that genes involved and that process involved is basically still under evaluation. The FGF23 has a very important relationship with PTH. Now, if you look at the FGF23, we know that the high phosphorus and the vitamin D is a very important stimulus for FGF23. Now, there are some studies which show that FGF can downregulate the PTH. There are some studies which can say that FGF can upregulate the PTH. But moreover, if you look at in the CKD, they are basically looking at the FGF suppression 23, increasing the parathyroid cell proliferation. Exact mechanisms are still under study as of now. Now, if you look at the modalities of treatment in these two, we have basically three kind of modalities we have. The initial modality basically is the phosphorus restriction, and then comes the vitamin D replacement, then comes the cinacalcet or active vitamin D. You look at the cinacalcet, it has been shown as a calcium mimetic, and if you look at the 3, 6, 9, 12 weeks, by 12 weeks, practically you get around 30 to 40% reduction in the PTH secretion. It's not only the secretion PTH come down, the calcium also comes down, the phosphorus also comes down, and the product also comes down. And this was a multinational study which looked at the PTH, calcium, phosphorus product, calcium, and phosphorus. If you go back and look at the EVOLVE trial, which did not show the difference between the cardiovascular modality with the cinacalcet, but definitely, especially in the elderly patient, it showed that the hip fracture, the fracture will come down in the patient above 65. Below 65, the fracture rates were same. Above 65, the fracture rates were definitely lower in the patient on cinacalcet. Now, if you look at the parathyroid surgery patients, going for patients in the patient of CKD, before the event or before the advent of cinacalcet, the rate was around 4.5, the rate was practically double. But with the advent of cinacalcet, the rate had practically halved. So that shows the efficacy of cinacalcet in preventing the further progression of the disease. Now, the vitamin D or the 125 AD analogs, if you look at there are 6 kind of analogs available. But practically, if you look at the studies, they have been shown to be practically equally effective. They lower the PTH secretion, but they can increase the PTH, they increase the phosphorus values and the FJ23 values, and increase the hypercalcemia. That is a point which you have to be very careful while using these products in this patient of CKD. Now, if you look at the FJ23 role is becoming under clear investigation in these patients. We know that cinacalcet will decrease the PTH, decrease the calcium, decrease the phosphorus. Vitamin D will increase the calcium, increase the phosphorus, but decrease the PTH. The SGF role, the values are little under study. And if you look at here, very interestingly, both the products are decreasing the PTH. You can see in the B slide. In the C, the calcium is going up on vitamin D, but going down on cinacalcet. In the D, you can look at the phosphorus is going up on vitamin D, but going down on cinacalcet. The product, the calcium phosphorus product, again, is going down on cinacalcet, but going up on vitamin D. The FGF23 is specifically coming down on the cinacalcet patient, but going up on FGF23 patients. And we know that vitamin D is a very important stimulator of FGF23. So this is becoming interestingly to be looked at more and more in the patient of CKD. And people are using it as a marker of the progression of CKD and MBD in these patients. Now, till now, we have been studying only the cinacalcet as being used for patients of CKD on dialysis. There is an injectable calcitide, again a calcium mimetic, works in a different way. It's an injectable therapy, can be given with the dialysis weekly, twice or weekly thrice. It was studied in a randomized controlled trial, and they looked at the PTH secretion and the calcium and phosphorus. Again, it was found to be non-inferior as far as the 30% secretion was concerned. But when you look at the 50% secretion, it was practically superior to cinacalcet. And it shows here, you look at the PTH, the cinacalcet is in the dark green, and the orange is the calcitide. It is more kind of suppression of PTH can be seen. The phosphorus comes down with the calcitide as the cinacalcet, but it's more robust the suppression of the phosphorus and calcium. If you look at the percentage suppression around by 14 to 16 weeks, you can see around 50% PTH secretion being inhibited by calcitide. We come to the management part. Now, first we look at the adult non-dialysis patient on CKD. Now, if you look at the monitoring part, we do the patient of CKD stage 3, we monitor basically PTH at baseline, and then maybe once in 12 months or maybe 6 to 12 months. Calcium and phosphorus every 6 to 12 months. Now, initially, we did have the KDIGO guidelines regarding the upper to the normal assay, the level to be kept in these patients. But now they have removed that upper limit. They are saying it should be the decrease less than upper limit. More so because the more PTH fragments are there in the CKD circulation, and it depends upon what lab we are using, what kit we are using to look at the PTH molecule in these patients. In the GFR is around 15 to 29. We are checking PTH more frequently, calcium phosphorus every 3 to 6 months. Patient on dialysis, PTH every 3 months, and calcium and phosphorus every 1 to 3 months. This is the monitoring schedule. The first and most important plan of management is to look at the phosphorus. The phosphorus has to be restricted. The hyperphosphatemia has to be treated in these patients with CKD. The phosphorus starts to go up when the GFR starts to decline between 25 to 40. We know that the phosphorus basically is linked to the mortality and morbidity in these patients. We are keeping a target of 4.5 with dietary modifications. If there is a persistent elevation of phosphorus more than 5.5, despite the dietary modification, we'll have to use the phosphate binders. In case patient is presented to us with the phosphorus of more than 6, Then we start the dietary restriction and the phosphate binder together. As of now, it is said that basically if the phosphate restriction to be around 9 milligram per day in patient with kind of reasonable nutrition status. We know that the patient with CKD do have the modified, the status is not quite good. In these patients, the more you restrict, the more chance of getting a more poor nutrition in these patients. The phosphate binder basically out of two kinds, the calcium containing and the non-calcium containing. Again, this has to be only used after we have made sure the dietary restriction is at the place and the dwell is not coming less than 5.5. Rather than looking at one value, you can look at multiple values before you decide to add a calcium binder. The calcium containing binders are calcium carbonate and calcium acetate. Again, there's a tendency not to use of the calcium containing binder much unless the patient is really hypocalcemic. The major non-calcium binders are the sevelamer and the lanethor. The second step basically comes to look at the vitamin D. Now, this is the only 25 vitamin D, and we normally can replace with cholecalciferol or algicalciferol, and with who are the patient who are deficient. The plan of management of the replacement of vitamin D is as basically as for a normal person. They have not given a separate guideline for a replacement schedule for these patients. We have to be careful replacing vitamin D in patients who already have a high phosphate or high calcium level, borderline high calcium level, because certain replacement or certain dose of vitamin D can push up phosphate and calcium level in these patients, which can precipitate the calcification in the arteries. The preparation and the dose are same as for a general population. The use of activated vitamin D is limited to patients who are not being controlled on phosphorus replacement or a restriction and simple vitamin D replacement. Again, the decision is not based on one value. Look at the trend rather than looking at a single value. Because sometimes there could be a transient elevation of PTH, which may only reflect adaptive response rather showing a progressive parathyroid disorder. A word of caution, we do not use calcium mimetics in our calcite to suppress PTH among non-dialysis CKD patients. So among non-dialysis, the only option is phosphorus restriction, simple vitamin D, and if the PTH still tends to rise, we can use the active vitamin D, again, very carefully, keeping that the phosphorus and calcium should not be on the higher side. Now, coming to the patients who are already on dialysis, again, the first target is to keep the phosphorus between 3.5 to 5.5. Calcium has to be less than 9.5. We may accept a little bit mild asymptomatic hypocalcemia of around 7.5 to 8. We need not rush in to treat that. Now we have the guidelines to keep the PTH values between 2 to 9 times the upper limit of the PTH assay. There's a wide range. So again, the decision is not based on one value. Look at the trend rather than making a decision on one value. Once you have restricted the phosphorus and brought the phosphorus in the normal range, then we look at the PTH value. Replace the vitamin D and then look at the PTH and then decide how to treat. Normally, if patient is symptomatic, the PTH should be more than at least 800. Or if patient has a metabolic bone disease, we expect a PTH to be at least more than 400. 6 times the upper limit of the normal should be there. We are not treating to get the PTH to in the normal range. Even if the PTH comes to less than 2 times the upper limit, around less than 150 or less than 165, we tend to stop the treatment of suppression of PTH. Again, as I said, to maintain the normal calcemia, maintain the phosphorus, and correct the vitamin D deficiency. Again, you can use a similar treatment protocol as we use for a normal population. For dialysis patients, we can use argocalciferol and cholecalciferol in depleting the vitamin D level. Again, the same word of caution, the patients who have already high phosphorus or borderline high calcium, replace slowly. Now, after that, comes basically the PTH option. We have the active, the calcium mimetics, calcitriol, or vitamin D analogs, or a combination of both. Now, if you look at the common practice, is to start with the vitamin D or calcitriol first, and then go on to calcium mimetic if required. Now, between the preparations of active vitamin D, none of shown to be much superior to the other calcitriol which has been used earlier. But there have been some suggestions to suggest that calcitriol will cause PTH separation and hypercalcemia more commonly, as compared to the analogs, which will cause the PTH separation more, but will cause the hypercalcemia less often. But again, I'm glad to see the clear-cut data to be published so we can make a decision. Calcimimetics, basically the choice of drug to use cinacalcet. Then, if not controlled, then we can use calcitide can be used. Now, if you look at both drug classes lower the pH values, but we have seen that they have a disparate action on the calcium and phosphorus level. Thus, the choice basically depends upon the serum phosphate and the calcium. In case the phosphate is less than 5.5, calcium less than 9.5, you can start with calcitriol monotherapy, but not daily. It can be weekly twice to start with, and then to be titrated depending upon the values. Cinacalcet should not be started in case the serum calcium is less than 8.4. The dosing strategy is empiric. The value of administering increasing dose of calcitriol and vitamin D analog to achieve target plasma PTH level while maintaining a phosphorus less than 5. But the phosphorus is very, very critical in these patients. Among patients who are already on calcitriol and the PTH is not suppressed, you can always add the cinacalcet provided the calcium is more than 8.4. It has been said very commonly seen in the patient on calcitriol, and around at least half the patient will require an additional therapy. They will not be able to achieve the PTH values what has been advised. Among patients with serum phosphorus of 5.5 and a calcium of 9.5 and persistently elevated PTH, decide the maximal therapy should be the phosphate. Initiate therapy with the calcium mimetic rather than calcitriol. Cinacalcet started in a dose of 30 milligram and then it can be increased up to 60, 90, 180 milligram per day. The dose can be increased in interval of 4 weeks until the goals are achieved. Do not start again the cinacalcet if the calcium is less than 8.4. If case the calcium is coming down less than 8.4, you can always add a calcitriol to push up the calcium value. The main side effect of calcium cinacalcet basically is hypocalcemia or GI side effects. And the GI side effects basically are sometimes when you cross 60 milligram, it becomes really a problem. The patient do develop a lot of nausea and vomiting. Then, despite your medical therapy, you're starting with cinacalcet and calcitriol or in combination phosphorus suppression, you may find the disease is still progressive. And that is called the refractory hyperparathyroidism and defined as a severe, persistent, progressive elevation of PTH that cannot be treated adequately with medical therapy, including vitamin D analogs and calcium mimetics, without causing a significant hyperphosphatemia or hypercalcemia. And that is defined as a PTH more than 800. Some people use the ultrasound size of more than 1 centimeter, or a volume criteria can be used to look at the refractory hyperpara. But basically, the patient should be symptomatic. And a PTH more than 100. The symptoms commonly are bone and joint pain, fracture, proximal muscle weakness, skeletal calcification, calciphylaxis, hypercalcemia, and hyperphosphatemia. Increasing PTH with hypercalcemia is basically a marker of tertiary hyperpara. Now, if you the indications of parathyroid surgery would be refractory hyperpara for more than 6 months with either calcium and a PTH phosphorus going high, PTH being maintained more than 800, patient developing calciphylaxis or a T-score of less than 2.5 or bone fractures, refractory pleuritis, bone pain and calcification and myopathy. So despite your best medical effort, in case you're not able to control for more than 6 months, plan is for a surgery. Now, basically around 10% of the patient of interstitial renal disorder may require parathyroid surgery, and it's a very effective tool to control the renal hyperpara, even which is persisting after the transplantation. We know that these patients will have hyperplasia, they may have a 4-gland disease, and some of these glands will descend into the retroesophageal and the paratracheal spaces. This is a very important part and which will make them very difficult to localize. You may have to use the best brain or best localizing methods to localize these ectopic or the descending parathyroids. And sometimes there could be ectopic parathyroid rest in the cervical thymus, which may become hyperactive and may secrete more PTH. So compared to the normal glands, parathyroid gland in the SKD have more nodularity. They have preponderance of oxyphilic parathyroid cells. They have more fibrosis, more sclerosed, and more dystrophic calcification. They can go to the size of 500 to 1000 milligrams and but remain histologically hyperthermic. Getting a single or a double adenoma are rarely seen in patients of ESKD. When you go for a parathyroid surgery, there can be 4 approaches. One is a targeted parathyroidectomy. You simply localize one adenoma and go, which is not very common. A subtotal or a near total parathyroidectomy, total parathyroidectomy with autotransplantation, total parathyroidectomy without autotransplantation. Now, this decision basically will depend upon whether the patient is planned for a recent transplant or not, whether this is the first surgery or the reoperative surgery, or does the patient have a compelling reason to avoid the reoperative next surgery. So these decisions basically are nothing like gray and we don't have a black and white to make a differentiation. Very gray zones are there. So depending upon the discussion and the clinical evaluation, the surgeon will decide which is the best strategy for it. Initial parathyroid surgery would be basically for a multi-gland hyperplasia. The subtotal parathyroidectomy is a very kind of the planned surgery is the most important here. And in case of the patient with post-renal transplantation who has a single adenoma or a single or double adenoma, there a targeted parathyroidectomy will be quite warranted. But when you're doing a parathyroidectomy, the cervical thymectomy becomes very, very important. So basically, when you're removing all the 4 parathyroid or 3.5, always go for a cervical thymectomy. Then comes the role of importance of PTH monitoring intra. Like for a thing, primary hyperpara, we have a very standard protocol of PI protocol, well established and well taken up. But in the patient of ESKD, there is no well established protocol because of 2 things. One is there are a lot of PTH variants being in circulation in these patients. So which assay you're using and which assay, which variant of the particular part of the PTH is being measured, that's very important. And then there's a prolonged half-life of PTH in these patients. It is around 6.6 minutes compared to 2.2 minutes in a patient with normal renal function. Still, whatever the limitations are, the PTH value can, in post-op PTH value can be compared to the pre-op and can give you a comfortable idea how the things are going. Some studies have taken a cutoff or 80% decline, and which has been basically used for MEN also. Some studies have taken a cutoff of more than 50% decline, but coming back into the normal range, that is 65 less than 65, which some people have claimed it gives you 100% cure as compared to the 92. The value which you achieve post-op will be a little higher than what you will get on the 3rd or 4th day of the surgery. So very important to guide us to see whether we have localized 3 or 4 or still one thing is missing, that it can be guided to. But it's a very difficult decision sometime in drop. So these are typical approaches. The subtotal or near total parathyroidectomy with the cervical thymectomy, as there is only 3.5 has been removed, half is left behind. We don't go for auto transplant. We can go for a parathyroid cryopreservation. In case we're going for a total parathyroidectomy, all 4 have been removed. Recommended thymectomy has been done. In that case, we go for auto transplantation of the sternocleidomastoid or a forearm, and we can go for a cryopreservation if available. In case patient for a resurgery or for a patient going to be long away from the transplant, and in that case, you can plan for a total parathyroidectomy with a cervical parathyroidectomy without going for auto transplantation. You may have a parathyroid cryopreservation for the future. Now, coming to the imaging modality in these patients. Now, conventionally, if you look at, we have been using the ultrasound and system maybe for localizing. There's a gathering experience with the choline opacity in these patients, which has been found to be superior with the ultrasound and the system scan. A newer variant of ultrasound called the contrast enhanced ultrasound is coming up and can give us a good differentiation for the focusing on these parathyroid. If you look at this was a study we looked at the retrospectively looked at the enlarged parathyroid, which are minimally minimal hyperpara to versus the severe hyperpara, that is PTH more than 800, and more than 800. And they did find certain characteristics which can be set with these patients who have refractory hyperpara. And they had looked at the volume of the parathyroid gland, the number of parathyroid glands in normal, calcification and the cyst score. The main thing was the contrast enhanced ultrasound. There are small kind of air bubble molecules that are injected into the system, which basically go for the veins, into the arteries, and to the lungs, and then to systemic circulation, and which they behave differently when they hit the ultrasound wave. So they give a different kind of enhancement on the ultrasound. And you can see here, this was basically a patient of 55-year-old patient with severe hyperpara, PTH more than 3,000, and you can see a lesion of 3.3 centimeter on conventional ultrasound. If you look at the grading of blood supply, it was grade 3. In the contrast enhanced ultrasound, you can see basically hyperenhanced in the early phase and isoenhanced in the late phase. Next, basically was an hyperpara with the PTH was not so high, it was only 443. Contrast intrasoyo a lesion of only 1 centimeter. The blood Doppler flow was only grade 1. And the contrast enhanced is showing only an isoenhanced lesion in the both early and the late phase. Basically, the basic assay modality still remains the ultrasound with hysteromy. Hysteromy may not be so helpful in the polyglandular disease, but ultrasound definitely is very helpful. The main thing is the localizing of the ectopic or the glands are not there in the neck. There, the choline opacity may have an advantage for us, but I think we still have to develop the number of patients to look at that data. Come to the last slide. The treatment plan basically the focus is initially on the phosphorus restriction. Replace the simple vitamin D and then follow up these patients in case the PTH is still progressive. In non-dialysis patients, we can use the 125 vitamin D can be used. If the patient goes on to dialysis, we basically can use both a combination of calcimimetics and 125 vitamin D to achieve the goal. In case we're not able to achieve, the surgery remains the best choice of action. I think I'll stop sharing the slide.
Thank you, Ravi, for a very comprehensive talk on secondary, tertiary, and primary hyperparathyroidism with CKD. I think there are a lot of takeaways, but I'd like to emphasize one or two things, as you rightly mentioned. Whenever the patient presents primary hyperpara with CKD, it's always thought that it is secondary, and I tell my residents, don't jump to secondary. There are PHPT with CKD also, and the trick is that if calcium is high, it is PHPT with CKD rather than secondary hyperpara. So that differentiation is very important because the surgical management is different for both the entities. The second is about secondary. As a surgeon, I can tell you is one of the most difficult parathyroid disease to treat. We get references from nephrology for secondary hyperpara. These are very difficult patients because they might require dialysis immediately after surgery. And besides, the surgical part is difficult. You may not find all 4 parathyroids. And as you rightly mentioned, thymectomy has to be added, but these patients do very well after surgical treatment. They have so severe bone pains, and that after surgery, it's so gratifying. And for the first time, they tell you that they are free of bone pains. So surgical treatment of secondary hyperpara is very gratifying, provided you do a correct procedure, So like you mentioned, I'll probably do a 3.5 or even a total parathyroidectomy without autotransplantation. That's a perfect procedure for these patients, where you have very few recurrences and the patients do very well symptomatically. But sometimes the indication for surgery may be tricky, because once you give cinacalcet, they have a PTH of like 157 and 158, what to do with these patients. But I think the indication of bone pain and osteoporosis, these are very two strong indications for surgery in these patients. Ravi.
Yeah, I do agree with your comment. If you look at the comment of the primary hyperpara with CKD, the kidney will not high. The kidney will be around say 1.5, 1.7, GFR will be around 45 to 50. Definitely with the GFR going less than 45 or less than 40, then the CKD hyperpara becomes more into picture.
Yeah, so as a nephrologist, I feel MBD is often missed in CKD. The other point, what I wanted to say was, apart from the PTH levels regarding indications of surgery, some people have intractable pruritus, calciphylaxis. So many of the times the skin lesions are confused with some infected ulcers. So in fact, that's calciphylaxis. That's another indication for surgery. So these two, uremic pruritus and calciphylaxis also are important indications where we have to resort to surgery. Just wanted to know, Dr. Ravi, from you, what's your experience with bone biopsy? I mean, some of the patients where the parameters are midline, that's the confusion always. I mean, what do you do for such patients? Do you do it?
I have no personal experience with bone biopsy. I think the PH Chandigarh or Badada may have some experience in the bone biopsy in these patients. But clinically, as such, I have not had an experience with bone biopsy. But while evaluating CKD MBD, the final word basically comes from the bone biopsy only. But the procedure is difficult to interpret. And I'm sorry, I don't have a personal experience in that. Sanjay Badada might have experience. Sanjay, if you get there, you can come in and enlighten us upon that fact.
Can't see Dr. Sanjay.
I think they were the only one doing the bone biopsy and the study on that. I think, but clinically speaking, doing a procedure is not difficult, but interpreting the bone biopsy is very difficult.
Thank you.
Just to add to that, calciphylaxis is an indication for an emergency parathyroidectomy.
Yeah.
That is one because sepsis can be very severe, as Dr. Manisha said. As soon as you have a patient of calciphylaxis, you have to go in for an immediate parathyroidectomy. Yeah. So I've had experience of 2 patients. These were like elderly women and typical skin ulcers of calciphylaxis, and after parathyroidectomy, they improved. So that has to be on the lookout for both the nephrologist and the surgeon.
How frequently do you look for this coronary calcification and all as a part of your CKD MBD? I mean, what's your experience with that? Because that's we don't get it done routinely because of the cost of when do you get it done? The coronary calcification, we generally do a screening, routine X-rays and all that. But what about TBCT? Any experience on that?
People have been doing abdominal X-rays that will you to look at the aortic calcification.
That we do, we quantify and all that, the calcification, but coronary calcification.
Looking only for CT calcium scoring basically the part of looking for the coronary vasculature can be done. But again, only the question is about the radiation exposure. That is there. Otherwise, I think normally you're not doing it routinely for our patients to look at the calcium scoring in the coronary artery.
Thank you, Ravi. So over to Siddharth.
Thanks, everyone. I call upon Dr. Rakesh Sai sir to give a vote of thanks.
Yeah. So thank you to all the speakers and all the chairpersons. It has been a great session where we have had a good interaction, and we have learned a lot during this session, particularly because we had we had the endocrinologists, we had the endocrine surgeons, we had the radiologists and nuclear physicians who were there with us, and I think it was really a great learning experience. I thank each one of you who have been who have taken out time to be here today and for attending this session. I thank everyone, and I thank Siddharth for taking all the efforts to get all these people together. Thank you. On that note, I think we can close the session and thank everyone.
Yeah, thank you. So we thank everyone, the IDEA team, all the chairpersons, the speakers, and the people in the back end, the IT team of IDEA Clinics, Raghav, then Avik and Ramanjanelu, who made this a success. May I request everyone to switch on their camera for one last virtual group photo if possible, please. And then we end our session. Thank you. Thank you.
Thank you.
Please switch on your videos for one last session, and then we end the meeting. Okay. Yeah. So we thank everyone, and we end this session here. Thanks one and everyone once again, and thanks to IDEA Clinic. Thank you, sir.
Thank you. Bye.
Bye-bye.
Bye.